can start, Professor Ayman. We're live.
Yes. Good morning, good afternoon, good evening, all my vascular family along the universe. It's nice to meet you again in our webinar session. I'm honored to welcome you all in our meeting today. First, I would like to thank Sigvar's group for supervising and sponsoring this meeting. And I am honored and really feel indebted to our speakers today, Dr. Homan Jaleh, Dr. Raoul Jindal, and Dr. Ma'moul Bashir. And I want to welcome the great panel, Dr. Lowell Kabnik from United States, Dr. Eberhard Rapé from Netherlands, Dr. Sergio from Italy, Dr. Khafir Serlat from Mexico, Dr. Malay Batal from India, and dearest friend, Dr. Mustafa Sulaiman from Egypt. Now, it's great to introduce my dear friend, Dr. Homan Jaleh. He's a consultant to vascular and endovascular surgery and the director of European Venous Center University Hospital of Aachen and Maastricht. Dr. Jaleh in the year 2012 had led the program of vascular surgery and intervention, which grew to become one of the most important programs in the whole Europe. Dr. Jaleh is the principal investigator of more than 60 articles, the most recent one involving the innovation of endovascular revascularization and its outcome. He is invited to many international centers and he presented more than 100 lectures. Today, Dr. Jaleh is going to introduce a very nice topic, venous stenting, how and when, together with classification of CVO. Please, Dr. Jaleh, the mic is yours.
Thank you very much, Dr. Fakhri. Now my voice is there?
Yes, very good.
Thank you very much for the kind introduction, and thank you very much to Dr. Omar and Dr. Fakhri for inviting me to this webinar. It's my honor to be here with my colleagues and friends from all over the world. So I am a consultant vascular and endovascular surgeon working in University Hospital Aachen in Germany and University Hospital Maastricht in the Netherlands. And today my topic is, one is the how and when the right indication, the right diagnostic for the chronic venous obstruction, and then the classification of the chronic venous obstruction. So I think we should start with the first presentation. Okay. So can you see my presentation? So you see a little bit of tips and tricks and right diagnostic, right indication and decision-making for the endovascular treatment of chronic venous obstruction. After it, we have time to discuss in detail this topic. This is my disclosure. So very important is, what are the signs and symptoms of the chronic venous obstruction? And regarding the right decision-making and the indication, the patient needs to have really signs and symptoms of this chronic venous obstruction. I had a young lady from Düsseldorf in my outpatient clinic who told me after 8 kilometers of running, she had small itching in her left leg. And there was a slight compression of confluence of the cava, for me, this is not an indication to treat this patient and put a stent, because after 8 or 9 kilometers of running, so she should reduce it 1 kilometer and just run maybe 7 kilometers. So the patients really should have real signs and symptoms of the chronic venous obstruction or PTS, as you can see, swelling, tension, heaviness, pruritus, and collaterals as sign. And don't forget the venous claudication. If you have a deep venous center, you see really a lot of patients with venous claudication, and they are impaired. Many of them are impaired due to this venous claudication in their daily life. So coming to the diagnostic, you see I divided it into preoperative, perioperative, and post-op. Very important is the duplex sonogram in the pre-op session. So we need a profound duplex done or performed by a really good duplexer or technician. We combine it in Aachen or Maastricht with a MR phlebogram as imaging. So in other centers, they use CT phlebogram. If patients had already venous stenting, then of course you have to go for CT. After having duplex MR and the anamnesis of the patient, you can then really decide or make your decision for treating or not. During the treatment, of course, you are using the ascending phlebogram. You need IVUS, very important, and therefore I made it red because this is one of the most important tools in the OR. And more we use after the procedure in the OR, the duplex, just to see how the flow is in the groin after the treatment. So, but again, duplex is the most important tool in the preoperative setting. And during the operation, of course, ascending phlebogram, the angiogram is very important, using it in 2-plane or multiple plane, but with IVUS, not only you can precisely decide for the size of stent and your proximal and distal landing zone, and also you can reduce radiation exposure and you can reduce contrast, the amount of contrast. And in a post-operative setting, again, duplex is very easy. Even I can use a duplex in an easy way because you can visualize the stent, the length of the stent, the shape of the stent, measure area, diameter, nearly you can do everything. If there are some further questions, then you can combine it with X-ray or CT phlebogram. So this is an example of duplex done by Erwin Thunder, our really brilliant duplexer and technician who works with us in Maastricht and Aachen. You see the groin, this is the left groin. You see the femoral vein as one main inflow vein. You see the deep femoral vein as the other main inflow vein, and you see the post-thrombotic trabeculation in both. And in this is not a dynamic image, but in this case, special case, it was a young lady, the inflow from the deep femoral vein was considered by us as enough. But of course, we can ask, what is enough? If is 200 milliliter per minute enough with our machine in our setting in Aachen? And we know that with another machine using by another technician, you may have another result. So there is no evidence, but experience. So very important, precisely duplex sonography of the groin, of the inflow veins, of the collaterals, and of course of the outflow. You can visualize it till the liver. So again, a patient, a young patient with so-called myturna, the compression in the confluence, or common iliac vein at the left side, I want just to stress the supine and upright position. In nearly every young lady who is thin, you can create with really small pressure, very small slight pressure, a myturna point. You can compress the vein just by putting the probe on the abdomen. So it is very important that we prevent this, this problem and perform a duplex in supine and upright position in order to say if there is a real myturna or not. And of course, I hope you can see the mouse here. You see the fibrosis of the vein. This is an important point which creates after years of compression. And we combine it again with MRV. This is the MRV in axial plane of the same patient, young patient. You see the real severe compression. Again, an MRV or CTV is performed in supine position. So the upright position and Valsalva, duplex in Valsalva maneuver is very important. These are just images showing you how easily you can follow up the patient after 2 weeks, 6 weeks, 3 months, 6 months, and yearly thereafter with duplex. You can visualize the stent very easily, the in-stent stenosis or thrombosis, the covered or over-stented great saphenous vein, and even with stent, you can compress the stent easily and change the geometry. These are some examples of our venous maps, which I received from Erwin Thunder, again, our duplex specialist or technician. You see really visualizing the deep system and the superficial system. He visualizes us the chronic venous obstruction, the collaterals, the reflux. Reflux is drawn with red, in red color. You see this is the reflux. So just consider this picture. This is an acute DVT due to a chronic venous obstruction in IVC. So these are really brilliant venous maps, which makes life easier, and we can easily do our indication or make our indication, and of course in combination with a good imaging, other imaging like MRV or CTV. So I told you we measure the flow above the ostium or orifice of the deep femoral vein, for example, in this patient 200 milliliter. These are another examples, as you can see, many patients with visualizing the inflow, the reflux in great saphenous vein, as you can see here, then the chronic venous obstruction, or in this patient, involvement of deep femoral vein and iliac tract. So very important, a profound diagnostic. Now coming to IVUS in 2 slides, just showing you how easily we can visualize the success with IVUS. This is this young patient in whom you saw the duplex and MRV. You see the very severely compressed proximal part of the iliac vein, common iliac vein, left-sided. And then after stenting, you see the compression has gone. Again, I visualize it in the next slide. You see the area was 31.5 square millimeter before stenting, and after stenting, showing in IVUS a good shape of stent. I tell it because Lowell is here, and a very good shape of the stent, which is important. So after stenting, we have 166 square millimeter. So now coming to some special points and maybe making a connection to the next presentation. Very important is the groin, is the inflow from deep femoral vein and femoral vein. And you see, just showing you the differences between these patients, it is extremely important to know how is the involvement of common femoral vein. Is there any involvement? Is femoral vein involved, deep femoral vein involved, or just one of them? Because that affects the indication, the decision making and our indication, or even contraindication. So showing you just now very fast our classification, which is based on anatomical expansion of the post-thrombotic trabeculation. You see type 1, 2, 3, 5, and just these 3 groups should be considered as really extensive chronic venous obstruction. The group 4A, 4B, and 5, because group 1 is just a compression anywhere. Group 2 is the post-thrombotic disease, but not involving the common femoral vein. Group 3, in this group, the common femoral vein is involved, but both inflow veins are patent. Really good chance to have a successful recanalization and patient who is doing well after the procedure. But these groups should be really indicated very rigid with a good and profound diagnostic. And the group 5 should be considered as contraindication. So what is the indication? Is a symptomatic obstruction in femoroiliac and cava level. Please, this is very important after a DVT. If it is a proximal DVT and we don't catch the patient in the first 2 or 3 weeks, and we cannot treat them in an interventional manner, then please use a conservative therapy and leave the patient for conservative therapy. Just see the patient, visit the patient after 6 months, but give the patient enough time to have the spontaneous recanalization. Maybe after 10 months, the patient doesn't need any stent. This is very important. Do not stent the patient after 3 months. And this is the contraindication. Just look at this phlebogram. There is no femoral vein and no deep femoral vein, just some collaterals and small veins. This is the group 5 of our patients. The severely impaired inflow should be considered as consideration in a normal daily life. Of course, in a research setting, this is another topic, like PTS access trial, but we are talking about the daily work. So DVT in the past 10 months, that means use a conservative therapy and see what is happening. Maybe the spontaneous recanalization is enough. And of course, asymptomatic patients shouldn't be treated. And contraindication from therapeutic anticoagulation. Just showing you a slide of endophlebectomy. In some patients, very rare cases, maybe we need endophlebectomy as a hybrid procedure. Of course, there is another technique. You see the group of the patients is 4A who might need endophlebectomy because you can remove the post-thrombotic changes from the common femoral vein, and then we have a free inflow from a patent deep femoral vein. So this is the indication for endophlebectomy. Post-thrombotic changes covering the orifice of deep femoral vein, but the deep femoral vein is patent. Another technique is, of course, putting a stent into the deep femoral vein. So this is a technique if you want to do the endophlebectomy, to perform the endophlebectomy, and you don't want to put a stent in the deep femoral vein, just puncture the mid femoral vein in the mid part of the upper leg, go into the trabeculation because we assume the femoral vein, as in this slide, is involved. So, but stay at the side of the deep femoral vein. This is the right leg. So we stay at the lateral side, and then with the help of the vertebral catheter, we go into the deep femoral vein with a terumo wire, just coming 1 millimeter back and then go up. Look, now going up. This is a technique which was mainly performed or many times performed by Richtergraf. So it's a very, very, I think, good technique in order to prevent endophlebectomy in patients with, for example, hostile groin or reduce. You do not want to go into these groins. So this is the technique, and a good technique. So then after recanalization in the right side, you can put everything away from the orifice of the deep femoral vein if you stand. Otherwise, you put everything into the deep femoral vein and you occlude your only inflow vein. So in my opinion, I have no evidence till now because we cannot compare studies together. We know that many colleagues have even very good results with Wolsten, like Marcia Luckley or Olivier Hartung. So, but in my opinion, we have new design dedicated venous stent. If you want to stent, if the indication is there, then use dedicated venous stent. And I don't want to make some advertisement for some special stent. I think in some positions, one is maybe superior to other, but these are all dedicated venous stent with good radial force and good flexibility. Just give you an example. What happens if you just take some stent into the iliac tract? So as take-home messages, my dear colleagues, a proper diagnostic approach is mandatory, mainly done because it's easy, it's cheap, and it's fast by duplex. Combining it with MRV and CTV, of course, again, patient is on table, in angio suite, or in OR, then of course you can use IVUS for precisely making the choice for the landing zones, or if you have to do the endophlebectomy or not. Do not overdiagnose myTurner syndrome. Nearly in every lady in a supine position, you can create a compression and then call it a myTurner. So this is not a myTurner. You need more just than a compression, like looking with IVUS, looking for collaterals, and duplex in prone and in upright position and Valsalva maneuver. The patient should have really signs and symptoms with impairment in his or her daily life. More strict indication, again, and respect the recanalization. Even some centers like Mark Garcia or Mert Duman-Tepe, and in some small patients also we did it, we can recanalize also femoral vein, but believe me, many of them are going to occlude again. So till now, there is no recommendation for the daily work. Use dedicated venous stents and in bigger size. For the iliac tract, if you want to decide between 14 and 16, use the 16. Because we know that these veins never reach 16. A 16 may reach maybe a diameter in the body of 14, and a 14 reaches 12. And many of them will have, after a few weeks, a thrombosis of the wall of the stent. So go for the bigger stent. And do not use short stent at myTurner point. If you want to treat myTurner point, in my opinion, the shortest stent you want to use should be 8 centimeters in order to prevent even one migration. Use IVUS, it makes life easier and makes the decision-making easier. Stent from healthy to healthy, of course, we know it. Adequate and aggressive anticoagulation, we start just 1 day before the procedure with our new oral anticoagulation, and a rigid follow-up, and very important is the 2 weeks follow-up, because if a patient has a early thrombosis, in 2 weeks, after 2 weeks, you can catch the thrombosis and easily treat it, and maybe treat the underlying disease or problem of the stent. But if the patient comes to you after 4 weeks and the thrombosis is 3 or 4 weeks old, it's too late. So just showing you a useless recanalization. I don't know the symptoms of the patient, but I just show you the treatment. This is the upper leg, but this is some few centimeters above the knee. We are looking at femoral vein. The colleagues used a really good dedicated venous stents, but just look, they stented from knee, 1 stent, 2 stent, 3 stents, 4 stents, 5, maybe yet, now 5, and 6. And it was occluded after 1 day. So probably after a few minutes or hours. So there was no inflow, and you kill all valves, and you have from the lower leg, there is no volume of blood. So just give you an example, or maybe we can call it use full recanalization, a patient mid-age with chronic venous obstruction of the cava on both iliac side, as you can see, and you see a filter in this area. The patient now was dealing 3-4 years with this problem. You see the filter here and the occlusion of cava. We went antegrade, bilateral. We had to puncture the right jugular vein, go from retrograde. You see the wires from everywhere. Then we crossed the main part. Then we made a dilatation, a simultaneous dilatation in order to crush the struts of the stent. That was after predilation. After using dedicated venous stents, we used 14 millimeter because 14 has good radial force in this area. And going to next slide, to last slide, that was before recanalization, that was after recanalization. And this is the voice of the patient. It is in German, but maybe I know Lowell, Ayman, and Dr. Omar, you cannot understand it, but there are many Germans, and then I translate it just in few words. The patient is coming to me in an outpatient clinic after treatment, and I ask him, please tell me, how are you doing now?
Zufrieden ist überhaupt kein Ausdruck. Ich bin ein neuer Mensch geworden. Mir geht so gut wie in den letzten 2-3 Jahren nicht mehr. Ich laufe herum, habe keine Atembeschwerden mehr und besonders, da ich während Monaten, also fast ein Jahr, gesucht habe nach Ärzten, die sowas tun würden und die meisten gesagt haben, das ist überhaupt nicht die Ursache ihrer Beschwerde, kann nicht die Vena cava sein. Nachdem sie geöffnet habe, laufe ich herum, ich steige Treppen wieder wie ein normaler Mensch und das geht mir fantastisch. Sie sind geheilt.
Super. Dankeschön.
So, thank you very much. I give just one translation. I ask the patient, please tell me, how are you doing? And I just recorded the venous map done by Erwin Thunder, and he said, I am like a new human being. Better is not just explanation. I am totally new. I couldn't went 200 meters. Now I can do sport. I have a new life. So, and at the end he said, you are my hero. Thank you very much.
Thank you. Thank you. It was a very nice presentation. Thank you. It was a very nice presentation, Homan. I like it very much, especially the last ballerina of the revascularization of the making a new IVC. This is perfect. Now I have the honor to get some comments from our great panel. It's a chance to ask Professor Lowell Kabnik from United States to ask or a comment or add what you would like to add. Please, Dr. Lowell.
I have nothing to add. It was a brilliant lecture. Thank you, Human. I do have a question for you. If a patient is a C3 patient with great saphenous reflux, ovarian vein reflux, and a May-Turner obstruction, which do you treat first and why?
So the patient has C3.
Swelling and varicose veins.
Exactly. And the patient has the great saphenous vein reflux and a pelvic
ovarian vein reflux and obstruction, left iliac vein obstruction.
A difficult question, Lowell. So in my very good question, thank you very much. In our regime, in our center in Aachen and Maastricht, we sure treat first it depends of course on the occlusion, but we go for treatment of the occlusion. If this C3 is the patient suffering from this C3? Is there really suffering? So, and of course, a little bit depending on the extension of the pathology, I'm not going to for a C3 putting 7 stents. But if it is a myturna, as you told, who needs 1 stent, and the myturna is a real myturna, So evaluated very well, approached very well. Then we treat for sure with one dedicated venous stent, probably 16 millimeter to 8 centimeter, the Turner syndrome first, and then look in a outpatient setting what the patient is doing. And then, of course, you told me the ovarian vein is refluxive, but you know better than me, we should measure the diameter, see if there are pelvic varicoses or not, if this is only ovarian and ovarian reflux or with other problems. But the C3, then probably if the C3 remains going for the varicoses of the leg.
Thank you.
Thank you.
Let me take on this point, Homan. Have you seen cases that when you correct obstruction of the deep system, you found that the reflux is actually self-cured? If you reassess after a couple of months, you found the great saphenous vein reflux, ovarian reflux might disappear.
No, I never saw that a reflux of the great saphenous vein was non-refluxive, but I saw, of course, vanishing of all collaterals and flow from the deep femoral and femoral vein into the right highway in the femoroiliac tract with a refluxive great saphenous vein, and with vanishing or improvement of many complaints in many cases. And these patients probably don't need any treatment of the varicoses vein. Of course, I saw, on the other hand, I saw patients after treatment of the chronic venous obstruction, as Lowell mentioned, who needed treatment of varicose vein additionally.
Okay.
Yeah, this is a good point. I have to reconsider. This is not only to abolish or do recanalization, you have to over the varicose vein. This is a very good point. Now I think it's time to ask Sergio. What's your comment, Sergio, or if you want to ask a question for...
Sure. I will take the chance because having one of the biggest experts in the world, and again, congratulations, it has been a really nice talk. So you briefly mentioned, Oman, about the
camera, Sergio.
You briefly...
Yeah, thank you.
So you briefly mentioned, Oman, about the antithrombotic attitude you have there with docs, but we know that it's really an open point in this moment how to perform the anticoagulation and also the antiplatelets role. Can you dive a little bit more in this and guide us on how to behave?
I think you brought it to the point. It's very, very controversial. And, you know, Alan Davis did this survey and there was nearly everybody is doing something else. And maybe all of us are right, but we go for new oral anticoagulation as the main part of the anticoagulation therapy in group 1, that means compression, in group 2, 3, and even the severest, the extensive disease 4A, 4B, and 5 with involvement of the influence. The question is, we every time start before the procedure because we saw that after these big procedures, after ending the procedure, when patients is in the recovery room and going to the ward, they have really lost 2-3 hours with anticoagulation. So we start one day before with, for example, rivaroxaban. But we do not use antithrombotic therapy, very seldom, but I have no evidence to tell that other centers who are using anti-thrombotic therapy, this is wrong. So for me, we need minimum of 6 months of anticoagulation in best cases, let us say Turner syndrome, to have the stent endothelialized with the cell of the patient in order to have the less thrombogenicity, which we could show in our animal study. I hope that will be soon published. And after 6 months, you have to see how the stent is, how the inflow is, how the outflow is, and then decide to stop it or go further for 1 year or even lifelong.
It is very interesting. And if I can just add a second question to this, overtreatment is a big issue in some countries. And you were mentioning IVUS in the peri-procedural phase. So we know that it's very good for the strategic planning of the procedure, but how is it important for you to decide if operating or not? The IVUS part.
The IVUS. So I never use IVUS as alone. I use in nearly many cases IVUS, but I every time consider the phlebogram, which I do in AP plane and in lateral plane, and see the collaterals. After treatment, I make another angiogram just in one plane, and then I use IVUS. With IVUS, I can see the total lumen, the shape of the lumen, my proximal landing zone, my distal landing zone. So I don't need another planes in order to reduce the radiation exposure. But every time it is never just one tool to say, okay, IVUS shows me now a compression. IVUS of course, shows the right compression. But I ask you, how many CTs did you see with many shapes of just one IVC? In the same patient, the IVC above the confluence is totally compressed with a bad aspect ratio, and some few centimeters more proximal, you have the perfect, very big IVC. So you can, if you put IVUS, you see, of course, this flattening or this compression or just fall of the wall of the IVC. So this is not alone an indication.
Sure.
But IVUS is very much more important for decision making where your landing zone should be, especially for the distal landing zone, seeing if in the front of the deep femoral vein you have some post-thrombotic changes or not.
Okay. Just one last quick one about people not speaking in German. Of course, we trust the report you made, but what would be an objective measures of quality of life in these patients, up to your opinion? An objective quality of life measure.
Yeah, this is very, very difficult for me. So we use the quality of the of life is really difficult because we have no evidence what is better and what is not better. Is SF36 or other things. So, but very important is for me the Villalta score. I know the shortcomings of Villalta score. I know the shortcomings of BCSS and other measurement tools and CAP classification. So I think you have to make a really good anamnesis. If you are doing a really research on the research setting, then of course you need as much as possible of these measuring tools. But very important, don't forget venous claudication is not considered in many of these tools.
Thank you so much.
Let me go quickly. Do you have any comment, Professor Ma'moun al-Bashir? Do you like to add?
I would. Thank you very much, Omar, Dr. Holman. That's a very good presentation. I just have a question. One of the most horrendous things that can happen to these patients is a stent occlusion, and when it happens suddenly, they seem to be getting worse results than they were before the stenting. So what's your protocol when that happens? And do you have a surveillance program for these stents?
If therefore, thank you very much, and nice. I stressed or mentioned at the last slide the postoperative evaluation. Very important, very, very important is the 2 weeks postoperative evaluation. Because if you catch the patient or see the patient after 2 weeks and the patient is suffering from a DVT, many of them do not realize it because they had over years many collaterals. If the main highway is occluded now after 1 week, the highway, the collaterals are again open and they do not realize it. They have not a very big leg. So they come to you and you realize the recanalized tract is thrombosed. So in these 2 weeks, you can easily lyse the tract or do percutaneous mechanical thrombectomy like Aspirex, GDI, Angiojet, and other techniques. So this is the most important thing. See your patients while you want to start them, and then after 2 weeks. The next thing is, if you have a patient with chronic occlusion, you have a problem. There are techniques, of course, with a sharp back of the Terumo wire 0.18 or 0.35, or with wires, with Asahi wires with higher tip load. You can recanalize many of them. But you have to consider you cannot vanish or remove these old thrombus or the new post-thrombotic changes. You just can dilate it. And you every time lose lumen. So these are patients who are doing not that well as before.
Okay. Well, my task is very difficult because we have 21 questions and we have 2 of the attendees raise their hand, and we have 56 countries looking into this webinar. So let me take the first question. Dr. Ahmed Ammar will open the voice for you to say the question yourself, Dr. Ahmed Ammar. Introduce yourself and ask the question.
Hello, can you hear me?
Yes, we can hear you, Dr. Ahmed.
Hello, everyone. I am Dr. Ammar from Mayo Hospital, Pakistan. I am Senior Registrar of General Surgery. It was a nice presentation from Dr. Oman, and I have learned valuable points from him. My question is that, is there any cutoff value of age after which you cannot attempt these stenting, and is there any comorbid conditions can affect this procedure? Because we have patients who are diabetic, hypertensive, chronic hypertensive, and antiplatelets, and multiple problems at the same time. So can we proceed with this stenting in these patients?
Just thank you very much for this really nice question, interesting question. Just to summarize, no, you can do the stenting nearly in every patient, but you know I am a friend of, to be honest, to be very rigid. So that means I give you an example. If a patient with a life expectancy of few months, with a severe swollen leg due to acute thrombosis because of tumor compression, you can really easily help this patient with just putting one stent in IVC or iliac tract, and the patient has a very, very improved quality of life in his next 6 months or 1 year. So that is a really difficult question to just be answered in one sentence or just saying this is our cutoff. Of course, if a 85 years old patient is coming to me and he says, I have a little bit swollen leg, I am not going to treat this patient. Or if a patient coming to me with acute proximal DVT, who I normally consider as for a treatment, and the patient is 80 years old, and he has a life expectancy of 5 to 10 years, why should I treat this leg in acute manner in order to prevent 40 to 50% of PTS in a patient in the next year? So that doesn't make any sense. So no, there is not a cutoff, but you should be, of course, rigid and do a very good anamnesis and preoperative evaluation, as I told. But consider even sick patients or patients, multi-morbid patients, for stenting if you think you can help them, because the stenting is easy and the complications rate is very, very low.
Thank you very much.
So I'll take one final question before the second part of your lecture. And this question comes from Turkey, from Professor Suat Dugansi. He said, excellent presentation. And he said, if you have a patient CEP5, when do you decide to operate on them rather than doing endovascular iliac vein recanalization? When is your cutoff point to operate?
Operate means open surgery.
Yes.
Okay, when I do opens, I every time try the endovascular technique, every time. And in our regime, if once I have no technical success, I would say 3% of patients, something like this, 4% of patients. Then we go for a second time in elective patients, in elective chronic venous obstruction. And if after 2 attempts, so a few hours, it was not helpful, and the patient is suffering really from his PTS, then we decide for open surgery, which is very, very seldom in the last 4 years, 5 years.
Excellent. So we can go ahead to the second part of your presentation. We have now 300 attendees, and we have around 400 seeing the lecture live on Facebook. So good luck.
Thank you very much. So my next presentation is originally prepared for Charing Cross 2020, and due to this condition situation, so unfortunately we cannot go there. I am now sharing my desktop. So I would like to close the presentation. Yes.
Hello, everybody. My name is Uman Jalai. I'm a vascular surgeon from Aachen and Maastricht. I thank the organizer of Charing Cross for giving me the opportunity to present my topic online, which is new validated anatomic classification of chronic venous obstruction in illofemoral tract and its clinical implication. This is my disclosure. I'm not trying to change the topic from venous to aortic, but just consider I would compare these 2 conditions with each other regarding the results after their treatment. Outcome after treatment of AAA versus outcome after treatment of thoracoabdominal aortic aneurysm repair. That would be a senseless comparison, I think, given both are aortic aneurysms. In this slide, we see illustration of 4 different types of the extension of chronic venous obstruction. Now, my question is, can we compare the first image with the last image regarding their outcome after reconstruction and stenting? This is a table from a paper published 2011 by Olivier Hartung. It shows the results after stenting for chronic post-thrombotic occlusions of the iliac tract. Just notice the differences of primary and of secondary patency between these venous groups. I don't think that the reason of such a big discrepancy could be the skill of the surgeons or interventionalists, or the type of the implanted stents. The reason is probably a big difference of the extension of the pathology in the patients included in these different studies. This table is from a recently published review performed by Williams, and it shows the results of venous stenting using dedicated venous stents. Just have a look on the 12-month primary patency of patients with PTS as pathology. They range from 59 to 87%. The type of the stent cannot be the reason of the big discrepancy, because Stephen Blake and Michael Lichtenberg both used VG venous stent. They both are very well experienced, and therefore the technical aspect can be also ruled out as the reason of this discrepancy. So again, the reason probably is the extension of the pathology of the patients included in these different studies. The classification is based on the anatomical extension of the post-thrombotic changes and the importance of the inflow. It should be simple and practical. Based on the available evidence, the additional involvement of IVC has a relatively low effect on decision-making. Therefore, a separate category for IVC has not been included. A 50% cross-sectional area reduction of the vein is considered as hemodynamically significant in this classification. As you can see, the group for patients with compression of the vein. The treatment is very easy and the patency rates are very good. Group 2 are patients with chronic venous obstruction of iliac tract without any involvement of common femoral vein with a perfect inflow. Group 3 are patients with involvement of common femoral vein but only cranial, the ostium of deep femoral vein. This group of patients can be treated in an endovascular manner with a distal landing zone of stent just above the orifice of deep femoral vein. Group 4A, post-thrombotic tract bucculation, go more distally and involve femoral vein. Deep femoral vein is the main inflow vein. These patients need either stenting into the deep femoral vein or an hybrid approach with endophlebectomy of common femoral vein. Group 4B are patients with involvement of deep femoral vein, and the femoral vein is the main inflow vein. These patients need either a hybrid approach or the extension of the stent into the femoral vein. Group 5 are patients with severely impaired inflow due to involvement of both femoral vein and deep femoral vein. These patients should mainly be considered as contraindication for any invasive treatment. In really selected cases with severe signs and symptoms of PTS, a recanalization of femoral vein additionally to iliac tract could be taken in consideration. The last three groups, 4A, 4B, and 5, should be considered as extensive chronic venous obstruction. These are preliminary data of the validation of this classification. Let us just have a closer look on the patency rates. They range from 60% in group 4A and B to 100% in group 1. This shows us the importance of the inflow. And here are the expert centers participating in validation of this classification. The classification of chronic venous obstruction helps us to aid the scientific reporting, to ease our decision-making regarding the indication and contraindication, support our therapeutic decisions, and to predict outcome easier. I thank on behalf of all participating centers. Stay safe and healthy.
Okay, very nice.
Thank you very much.
It is very nice indeed, very nice and very conclusive. Although we all missed Charing Cross, but now you can get the spirit of Charing Cross.
Charing Cross feeling.
Yeah, exact. I think we can still get one or two questions before we do our polling. Can you do questions, Dr. Omar, from the attendees?
Okay, we have 3 questions asked from the panelists. If we can open the voice for Dr. Hisham Osman. Dr. Hisham Osman, you can speak now, introduce yourself and ask your question. Go ahead, Dr. Hisham.
Yeah. Can you hear me now?
Yes.
Yes, we can hear you.
Yes, you can. Thank you. Okay. My question for Dr. Homan. I'm Dr. Hisham Osman. I'm a vascular surgeon from the state of Qatar. I'm sure you came across young ladies coming with unilateral leg swelling, and you investigate them heavily. You don't find anything, and eventually you come across a maternal syndrome that's been confirmed, but the symptoms is only leg swelling. And these ladies are obviously, as you know, they're greatly bothered by the leg swelling. Would you consider stenting on those ladies? If you confirm this is definitely maternal syndrome, would you consider stenting? And if you've done it in the past, would that improve the symptoms?
Yes, I would consider this. Because you mentioned doing really a profound evaluation and having everything just telling us this is a myterna in supine and upright position, and talking to the patient, to be honest to the patient that we have no guarantee that the swelling will be improved or the problems will be improved. If the patient is okay with that, yes, I would go for stenting.
Okay, so we have 4 minutes left before the next lecture, Professor Mamoun. So let me take the question of Christina Mansour. We will open the voice for Christina to ask her question.
Yeah, hello.
Hello.
Hello, Christine.
You want me to ask you a question, but everything is clear to now. So basically, I'm just like focusing on what you guys are saying, and it's excellent. Thank you so much.
Thank you.
Yeah, but now I don't have any question. But if I have a question, I will raise them up. I think there's a raise them up here. Yeah. Okay, sorry. I didn't realize that. Thank you.
Okay. Do you have a comment from Professor Loyal Kapnick or Professor Mamoun El-Bashir in the couple of minutes we have left?
Yes, I do. I think the question that was just asked was a really germane question. In the United States with C3 disease, we've had an overwhelming increase in venous stenting. And a lot of those patients have not been helped. So as Hooman said, I think it's really important to make sure what you're dealing with. This is what the swelling is from. And really, the last part of it would be a May Thurner. So everything else needs to be ruled out before you go ahead and stent that patient, because you'll have concomitant disease as well. And sometimes it's very difficult to tell, but make sure that. And the question is, you've got a 30-year-old female and you're not sure, are you going to stent that? Or if you have, I'm going to ask Dr. Hooman Jolly the question. You have a 30-year-old female with C3 disease, swelling. You've ruled out everything else. You're going to stent her. What are your concerns about pregnancy?
Thank you very much, Lowell. And thank you again for making this nice but difficult questions. I would consider independent, not regarding any pregnancy. If the patient, I ask, because these are mostly young patients, I ask them if there is a plan in the next week or months or time, then of course we can wait. But if there is no consideration, no active planning, then I would go for a stenting if, in my opinion, the indication is there, regardless the pregnancy. Because we have many patients now with stent who was pregnant, and we also see them before the time of pregnancy and after it, and they are doing well. So really very seldom I saw compression of stent due to birth of the child. So this is, or due to the pregnancy. So nearly regardless to it, of course, again, I ask if there is a planning, then I would wait, because this is not an acute condition which this patient is suffering from, maybe 3 years, 5 years, 10 years, or 2 years. So then we can wait another 1 year. But if not, then I would do the stent.
I have one technical question.
Oh, okay,
please.
Lowell.
Thank you. The technical question has to do with a chronic venous obstruction, a thrombotic lesion. When you are approaching that and you're using your high pressure balloon for pre-dilatation, do you go to nominal or do you go to burst pressure? And what do you do post-operatively? I mean, post-stent.
Yeah, we use every time the Atlas balloon. It means we go up to 14, 15, or 16. And every time we use the same size of the balloon as we want to stent. So let us say 12 in femoral vein, 14 in femoral vein to external iliac, and 14 to 16 to the common, and IVC much bigger. And then we stent, and again, we use the same balloon and post-dilate the stent to the nominal diameter. But I told you, we published a study in a phlebology 2 years ago. No, not even one of these stents reaches the size of this nominal size it is given on the package. So it doesn't mean that these stents are bad. No, but the tissue around it doesn't allow that the stent, which could be 16 millimeter, reaches 16 millimeters. So a 16 is probably 14, 40.2 or 40.3, and the 12 is less. So therefore, we go for a bigger stent.
That's very nice technical tip. So let me give the mic to Professor Ayman to introduce the next presenter. Professor Ayman.
No, before we do that, I would like to thank Homan. It was a great lecture. Thank you very much. I would like to thank all the group, because we have now more than 500 all over the world in more than 60 countries joining us. It's great. I think it is a very successful event. Thank you all. Before we ask Dr. Ma'moon, I'll ask Dr. Omar to make the polling, the first polling. Are you ready, Omar?
Yes, I am ready. If we can put the first polling on the screen. Yes, I will read the polling, and each of the entity can select one of the 3 options. In patients with successful iliac vein stenting after iliac vein occlusion, how important would you rate the post-operative use of graduated compression stocking? A, very important, B, medium importance, or C, not important at all? We have 30 seconds to answer this question. You select your answer and submit, and we'll show it live. It's a very democratic system. It doesn't allow for any errors or hacking, so you will get an honest assessment out of the 600 or more plus attendee. So we are like in very big room in Charing Cross, full of candidates. Can we see the results? Okay.
Great.
Okay. So 73% say very important, 21% medium, and only 6% not important at all. Okay, so up to you, Dr. Ayman.
Thank you. Now I am honored to introduce my dear friend, Professor Ma'moon al-Bashir. He's a consultant of vascular and endovascular surgery and consultant of organ transplantation. He is a fellow of Royal College of Surgeons, Edinburgh and Ireland. He has Jordan Board of General Surgery and Vascular Surgery. Ma'moon is a fellow of International College of Angiology and American College of Transplantation. He is the director of an Institute of Ultrasound Education and CME director of International Health Academy and CEO of Venous and Wound Care Center, Amman, Jordan. Professor Ma'moon is going to discuss a very nice topic. He's going to tell us about vascular oncosurgery. Please, Dr. Ma'moon, the mic is yours.
Thank you, Ayman. Thank you for the kind introduction and for the kind invite to be part of this very successful sort of online training program. Let me just, if I may, find my presentation, which is...
And congratulations on shaving, Professor Ma'moon.
Oh, thank you. I was worried I'm going to scare a lot of people off, so that's why I thought I'll do this. Let's... so you go with the share screen button, is that right? Which is...
You go on the share screen, which is the green button at the end.
Sure.
And you would have been open your PowerPoint ready and share the screen of the PowerPoint. It gives you multiple options.
All right, let me just...
So share screen and select the window for PowerPoint.
All right, and
welcome, Raul. You must have been very busy in India doing endovenous lasers.
Screen.
Yeah, you press on the green
all right,
button. That's it.
Here we are.
That's it. Yes, we are. Okay.
I'm one of the generation. I don't know what you call it, but the generation which is in the middle, so the 50s, the 50-year-old generation, were technically a bit on the go.
You're very young, Ma'moon. You're very young.
Well, thank you very much, my dear friend. So vascular oncosurgery, this is a very surgical topic, to be honest. We're going to move from the interventional arena to the extremely surgical arena. And it's, so just let me get, how do you advance these slides? All right, so what is vascular oncosurgery? It's surgery of tumors of or closely involving vascular structures. And this is what makes vascular surgery such a unique spectrum, because vascular surgery involves all areas of the body, and it has great interest for multiple specialties as well. That's why when you get a pathology that affects these major parts of the anatomy in different either compressive or invasion ways, then it's of great interest for the vascular surgeons to be involved with this. Vascular oncosurgery is almost becoming a separate specialty, where, as you are all well aware, there's so many interests in vascular surgery, and people are trying, especially in specialized centers, to get the volume of cases that they can develop a great interest in this. The English say, if you want to get something done, give it to a busy man. So when vascular surgeons get really busy, they find a new area of interest. This is an apple. This is to quote the CNN ad targeting the president, which emphasizes the facts. So we should always stay online with the facts. And I bring this up because we need to emphasize the role of surgery in cancer care. Surgery provides zero-order kinetics of tumor removal. I'm a great believer in surgery in oncotherapy, mainly because, with the exception of few hematological malignancies, the only modality which probably gives the patient cure or the potential of cure is probably surgery. There are great advancements in this arena. However, surgery is still the mainstay. Even with tumors that you can shrink down right to smaller sizes, you're not winning unless you remove the tumor. Its contribution to cancer treatment in concert with other modalities is evident, and advances in the treatment of cancer will derive from improved orchestration with these modalities rather than improved operative techniques alone, to quote the great Bernard Fisher. So what sort of areas are we talking about? Well, there is a small entity first we'll touch on, and it's called vascular tumors. Vascular tumors would include head and neck paragangliomas, neoplasias of the vessels, which has a tremendous multiple classifications. This is one of the simplest ones, and vascular lesions mimicking tumors. Out of this subset of vascular tumors, we're going to talk about the head and neck paragangliomas in specific, because we're talking about solid tumors that are a challenge for the oncosurgeon or the vascular oncosurgeon. The rest of the slide are areas of interest. However, they do not come under the umbrella of vascular oncosurgery. The head and neck paragangliomas are quite interesting pathologies or tumors, and they do have multiple classifications, but the one I find most useful is the one which classifies them in relation to their location. So more than 80% are located in the head and neck. They make up about 0.5% of all head and neck tumors. And paragangliomas are rare neoplasms that are derived from epithelioid cells migrating from the neural crest in close relation with autonomic ganglion cells. They're named after the site of origin, but the two main groups are the cervical ones and the skull base ones. The carotid and vagal ones, cervical ones, are probably the ones that vascular surgeons will come across mainly, and those are the ones that we will be discussing in this presentation. Just to give you a brief historical background, this is a pathology which has been around for a long time. I have special interest in medical history, and in my old days in London, I used to go to this old antiques market where you collect books, old books, and I found a surgical book, 1886, which discusses in part of it the paragangliomas. It does talk about Meidel removing the CBP successfully, and it emphasizes how difficult and deadly the therapy is. The unfortunate thing with all these textbooks is the mortality was 100%. It wasn't until 1903 that Shoda removed the first carotid body tumor with preservation of the carotid body and no nerve injury. I'm going to discuss this through our own data. So we've been sort of fortunate, or maybe unfortunate, to see a lot of these tumors in the past 20 years. We've seen 66 tumors in 61 patients, with a lesion history dating back 6 months to 30 years prior anteceding them. And this is in Jordan, our center in Jordan. And there's a reason for this, because a lot of surgeons during their career wouldn't see that big a number of carotid body tumors or paragangliomas. And the reason is twofold. One, some of these cases were sort of lingering around, not being treated surgically for a long time, mainly because of the absence of specialized units or expertise to deal with them. And that's why we found some cases of dating back to up to 30 years, with diagnosed but not treated. And the other one, we tend to be a sort of a country of massive medical tourism, and we get a lot of patients from adjacent countries. And one of these countries is Yemen, and Yemen has very high altitude, where they have a huge incidence of carotid body tumors. In fact, one of our friends there, surgeons, have a massive series of these. They're more like a neoplastic, like a hyperplasia syndrome, rather than a true neoplastic syndrome, but the eventual result is the same. They do get the tumor, they need to be treated. Some of these will be initially misdiagnosed as other things. In our series, 12 were. and 10 were discovered after we started our duplex surveillance program. The diagnosis is usually suspected clinically and confirmed by duplex. It's further confirmed, and you get the absolute anatomy with it, with CTA, MRA. In the old days, it used to be angiography as a first line, but now all patients will get a CT angiography or MRA, and that will not only give you the anatomical detail and the invasion areas and the soft tissue extension, but it gives you also the relations to the vasculature and subsequent surgical therapy plan. Angiography has a massive role. It does have a characteristic vascular blush. It also shows the goblet deformity, what's called the goblet deformity, which is anterior displacement and splaying of the bifurcation. It confirms the diagnosis. In addition, it shows you blood supply. It can show you bilaterality when you image both sides. But its main focus has been with the advent of preoperative embolization for these tumors. And that's, you know, an area of interest for many, especially people who work with these tumors. For a certain period of time, we were very keen to embolize a lot of these patients. We did actually use embolization, preoperative embolization in 11 cases. However, we sort of abandoned preoperative embolization for two reasons. One, because of the complications. Ischemic renal nerve injury, we had it in one, occlusion of the external carotid in two, access problems in one. And the other one was, it did not give us the advantage that it's supposed to be. The advantage was reducing surgical bleeding. In fact, with the current surgical techniques and the modifications and, you know, the experience, once you take off from the learning curve, the blood loss is not that big an issue. And it also had a minor disadvantage where it's when done, sort of, you usually do it 48 hours before, it just makes the dissection that little bit more difficult. The surgery itself, we operated on 64 tumors in 59 patients. 5 patients had more than one tumor, bilaterality or multicentricity. The surgical approach was similar in all patients. We had to sacrifice the external carotid artery in about 14 cases. We had unfortunate episode of ligating one internal carotid as a last resort in one case, which was a lady who was very lucky that she did not sustain any neurological deficit, even with that. We had ICA interposition grafts in 3 cases. The reason for us having these slightly higher rates of ECA sacrifice and sort of interposition graft, because we operate on Champlain 2 and 3 mainly. In fact, none of these cases was a Champlain 1. Well, the surgery, probably many of you are familiar with this. This sort of includes the usual positioning, exposure. We are very careful to dissect everything, especially the distal controls of the ICA before we start removing the tumor. With the advent of bipolar and ligatures, the dissection slightly easier. I myself like using unipolar, to be honest, and I sort of, you know, you get to a degree where you're doing this pretty fast, so you wouldn't, with very limited blood loss, so it's not that risky of a procedure. And once you get an entry into the periadventitial plane for the tumor, or the white line of the tumor, then you're almost home and dry. You haven't done it until you've done it, and you've done a few of those. You struggle with the first few ones, and then you know, there's a way that you found your way about doing the distal dissections, proximal controls, and proceeding with the surgery. Once you removed, you know, hemostasis is essential, and preservation of the vessels. We, in some cases, we do check with the duplex scan if we're worried about the ICAs or the control of the completion result, but in most, is the clinical picture at the end of surgery is enough. Which brings us to the Champlain classification, which is an intraoperative classification. It classifies the tumors according to their adhesion or invasion into the vessels. So Champlain 1 is localized tumor, Champlain 2 adherent tumors, Champlain 3 intimately surrounding the vessels. In fact, 3 now has a 3B, where it's a proximal bifurcation, a tumor behaving like a very aggressive tumor without involving the nerves, the cranial nerves themselves. About 67% of our patients were Champlain 3, which explains some of the higher rates of vascular procedures, including the ICA's interposition grafts. There are a few maneuvers intraoperatively that you can use to ease the access for the distal ICA, including, jaw dislocation or mandibular transection, obviously nasal intubation, styloid process removal. All these we've used one way or another in some of these cases. Most cases you probably wouldn't need to use any of them. So results, we had one major stroke leading to in-hospital death. This was an unfortunate case where, to be honest, she had a malignant tumor, which was post-operatively found to be so. And malignant tumors are prothrombotic. They're difficult to diagnose pre-operatively. You only can, almost do that with the extensive post-mortem histological studies, etc. We had one late death, which was also a malignant tumor, so both mortalities were related to malignancy. To have minor strokes, completely recovered, 10 cranial nerve injuries, most of these are temporary. 8 had complete recovery and 2 of them had partial recovery. We had one incomplete tumor resection, and that was a massive, massive tumor that we thought, it endangers the patient's life to continue with it. Very elderly lady. 2 malignant tumors mentioned above and 2 endocrine active tumors. Brings us to the familial cases because of the bilaterality and multicentricity. So we had 2 families, and we started noticing these familial cases and doing our surveillance program based on these familial cases, where we, if we get one case, we ask them about the rest of the family. And in the Middle East, they tend to have large families. And we did find a couple of families that have, one family had 3 sisters with a familial form, and another large family of 11. On surveillance, we had 3 siblings with tumors. 1 had resection of both tumors, 3 had resection of 3 tumors, and the rest declined treatment, mainly because of the stigma that is socially attached to the family when they get, all treated. Recent genetic studies have shown that there is, a gene responsible for these cases with the Krebs cycle metabolism and mitochondrial genetics, and it seems to be the explanation why do they get the familial cases. Multicentricity and bilaterality is observed in our series in 4 patients. One was a 31-year-old female who presented with a left-sided carotid body tumor and a synchronous retrocable. We've done all tumor removal. So we do it in staged manner. We do the carotid body first, and then subsequently we do the abdominal surgery. Another had the glomus legali and a carotid on the same side, and 4 patients had bilateral tumors. This is probably concludes my first part of vascular oncosurgery with emphasis on the paragangliomas and the carotid body tumors. And it brings us into the second one, which is probably more of interest to many surgeons, because this is a multidisciplinary, multi-specialty therapy. And you can only develop this sort of practice if you develop your relationships with the other surgeons. And it's usually a referral service where other surgeons will ask you if you can, help them with this to start with, and suddenly you're getting the cases because you start being known for them. It's a multidisciplinary thing because you need the general surgeons, the orthopedic surgeons, the plastic surgeons, the oncosurgeons, all these specialties. And we've done cases with all these specialties. I'll start with the first group, which is the mediastinal tumors. This is one of our cases, a lady who came in with a benign mediastinal tumor, 9-year history that is completely obstructing the SVC. And she had in her home country an attempted removal, which ended up with a bit of bleeding. They closed up and stopped the surgery. When she came to us, she was very symptomatic with SVC syndrome, which is a horrible disease to have, because these patients, they sneeze and they suddenly dizzy or faint, or they laugh and they're faint, very swollen face. And we proceeded to do her surgery. It was an auricular internal jugular bypass using a deep femoral vein. It's a very nice surgery to do. It does need a lot of preparation pre-hand because you need to scan all the vessels to know what's patent, what isn't. On this lady, the left internal jugular was the only vessel which was patent. Post-operatively, about a month subsequently, the features for her face returned back. She, her symptoms greatly improved, and it's a life-changing experience for a lot of these patients. Removal of the tumor itself, especially with the thoracotomy, it's a major undertaking, and it takes time because you've done the removal, then you have to do the bypass. It's something you do for young people who tolerate the surgery and who have the SVC syndrome. Interventional part of this is non-existent because this is a compressive lesion, so you cannot do anything if you do not remove the compressive lesions. I don't know, I managed to stop here or continue with the
we can take a few questions. Yes, Professor Ayman, if you open the mic.
Okay, thank you very much, Mamoun. This is very interesting, and it is very nice to stop for a few minutes to get some questions. This is a very interesting topic, and this showed us how it is important for multidisciplinarity in our hospitals, and I like your dissection very much. You are making a very neat surgery, in fact. I'd like to ask the panel, let's start by Dr. Sergio. Do you have a comment for Mamoun?
Sergio is not with us. We have Loyal Kabnik and we have Raul, and I have 2 questions from attendee. So whatever you want, Professor Ayman.
If we don't have a question from Professor Kabnik, let's go for that.
I don't have any questions. I'm learning.
Okay.
Thank you.
Okay.
In
of the attendee, we have 2 questions, Professor Ayman. I will take them. The first question from Yunij Baran. Yunij Baran will open your mic and you can introduce yourself and ask the question. Yunij Baran. Welcome, Yunij. It seems we lost his connection. We can take the other attendee, which is Ghazi Al-Nabolsi. We open you, Professor Ghazi Al-Nabolsi. You can ask your question.
Good afternoon. I want to thank all of you and Dr. Mamoun. Actually, I have 2 questions for Dr. Mamoun. First of them, about carotid body tumors. Do you check for metastasis before you start the surgery? Second question for you, for vaginal tumors, what's the indication for resection? Thank you.
Okay, thank you very much, Ghazi.
I did not get the second one. For which tumors?
For vaginal tumors.
Or vagal tumors, yeah.
Yeah.
So thank you very much for the nice question, Dr. Ghazi. Regarding the first one, malignancy with the carotid body tumor, as you know, carotid body tumors or paragangliomas are mainly benign. They can turn malignant. Some literature quotes the number 10%. It's probably less than that, somewhere between 5 and 10%. However, malignancy, to diagnose malignancy, have been difficult in the past, because you can only do it through invasion into the lymph nodes or the behavior of malignancy. They do not usually metastasize until very late. They do compress adjacent structures, and they can even grow very fast suddenly to compress even the trachea. So they cause more symptoms than the usual painless pathology of the benign tumor. Isotope scanning and PET scanning recently has been very helpful, because it can give you an indication of the malignancy potential. Histological invasion into adjacent lymph nodes, and that's why you always have to take the lymph nodes if you see them intraoperatively to be enlarged. The malignant tumors, unfortunately, tend to have very bad results because there isn't much therapy for them. Even radiation therapy, which is used as a palliative technique in some cases, is not that effective. Regarding vagal tumors, out of our series, I probably didn't go into much detail of that. We had 8 glomus vagalis, and they're very interesting tumors to operate upon. In many of them, you have to go distally with a dissection to get the control, and in some of them you can lose the vagus in part or total. The problematic ones is when you get bilateral glomus vagale, and that's quite a problem, because the potential for complications is even higher. We tried in our cases, in most of them, to preserve the vagus successfully, with some temporary compromised function, but in 2 cases we couldn't. So they tend to be a bit more difficult, and if they're very high, it's not a bad idea to get a neurosurgeon on board, just in case you get to go higher to the base of the skull.
Again, thank you, Ma'moon. We have increasing the attendees. Now we have more than 600 all over all platforms, either through Zoom or Sigvaris page, Facebook Sigvaris page. Thank you all. Please, can you keep on, Dr. Ma'moon?
Sure. So I'll resume the share, which brings us to the second group of these interesting tumors or malignancy that invade into major vessels, and that's the germinal retroperitoneal tumors. Most of these tumors are metastatic from gonadal tumors. They usually present late due to organ compression and vascular involvement. They include the seminomas, teratoma, and embryonic carcinomas. One of the first cases that got me interested into vascular oncosurgery is this case. This is one of our cases. Is a young man, a university student, who came in with a sort of a belly which looked like a 9-month pregnant lady. He had a massive retroperitoneal germinal tumor. He had a seminoma operated a couple of years earlier, and he was refused surgery because, as you can see, most of the major vessels are involved in this tumor, including the SMA and the celiac. His symptoms were bad enough that he's sort of vomiting all the time, and he's sort of withering away. He was a big man and just reduced in weight. So it was to start with, to be honest, wasn't sure how curative we're going to be, but I was definitely keen to reduce his symptoms. So we went in with a sort of a Mercedes type incision, and we couldn't get the tumor in whole following the dissection of the major vessels. We did get it in 2 portions, however, and he done very well with it. He had a minor recurrence 3 years on, which was also removed, and he's done very well indeed. And that's the good thing about these tumors. They're anatomical, they're compressive, they need the aggressive effort to remove them, but once you do, you've done the patient a great service. I do not believe any patient should be refused surgery for the complexity of the surgery or the risk of it, because they have no other option. Retroperitoneal tumors, primary retroperitoneal tumors, especially sarcomas, are another group which falls into that category. Although they represent 0.3 to 0.8% of all neoplasias, and they're mostly mesenchymal in origin, they do happen in a younger age group. They tend to present very late, and when they do present, you know, they're causing a lot of problems. They are critical subset of tumors because you need to get the whole tumor with the invaded viscera or organs without rupture of the tumor intra-abdominally, otherwise it will seed and metastasize. And I'll take you through a couple of those. This is one of the cases we had a few years ago where it was compressing the aorta, the renal vessels, the kidney on one side, and although it was an incidental finding, but the size of the tumor was quite advanced. This is another view of the tumor, and you can see how the whole side of the aorta is pushed to one side and it's invaded on whole one side. When they invade vessels or invade organs, viscera, you should not attempt to dissect them off. They should be removed with the invaded vessel or viscera, and that because that gives the patient the best chance of cure. One of the questions I get asked frequently: what do you do about confirmation of the pathology, histology? Do you take histology beforehand or not? A lot of these patients come to me being diagnosed histologically, so histology is already made. However, if I see these and they fulfill the radiological criteria, and I'm convinced that this is a retroperitoneal sarcoma because of the features for the patient, the radiology and the clinical features, I do intraoperative removal, and I do not take the risk of disseminating the tumor through preoperative histology. This tumor was removed, in whole, with the aorta segment that was invaded as part of the tumor as well, part of the colon and one kidney, and the aorta was totally replaced. We also covered the aorta. Usually in these patients, when you replace it, I use the PTFE and cover it with the visceral peritoneum for protection and reducing the risk of subsequent infection. Some of these cases, it will be the IVC, and I'll do exactly the same with IVC replacement. Brings us to a next group, which is the liver tumors. I happen to be a liver transplant surgeon. I have a special interest in liver malignancies. And liver tumors are quite, interesting because if you do not have the option for liver transplant, for liver tumors, mainly SEC, which fulfills the criteria and the child classification of the patient is adequate, then you have an option for resection. And resection of these tumors, especially when they're very large, is quite demanding, and you have to worry about the residual liver function as well. In this case, most of the the liver was taken by the lesion, and we do a pre-maneuver of embolization of the affected part of the portal vein, so that the other part of the liver, the normal liver, will hypertrophy, and then we can do the resection, and that's what we've done in this case. And you can see the embolizing material everywhere in the embolized part, so we can preserve part of the liver. The right lobe of the liver is all embolized. The left lobe is hypertrophied enough to give liver function post resection. And once you resect, in this case, we needed to reconstruct the portal vein, reconstruct the cava using the gonadal vein, but the patient has done very well. And because they're normal livers and young, relatively young, they do very well. This is a fibrolar Miller type of tumor histologically. This is another one where also you do a resection and reconstruction of the portal vein. Most of the time, you have enough space to re-anastomose the portal vein as it is. In a recent case we had a couple of months ago where the portal vein was also invaded. We had to replace it. I usually use the internal jugular vein to replace the portal, because it's a big enough vein with no valves usually, and does the job nicely. Renal tumors, these are probably the most common tumors that vascular surgeons will probably get referred and face, which are renal tumors invading the cava, and they usually sort of referred because the potential for cure when you remove the tumor and the invasion is very good for these patients. Without adequate surgical removal, they do not have much of a chance. So renal tumors in general, they're benign or malignant, adenomas, oncocytomas, angiomyolipomas, fibromas, but the most important one is the renal cell carcinoma in the adult population. Specifically, the basic pathogenesis of these is well recognized to many. If usually they happen in the 5th decade, most of these patients are usually healthy, young, and if you give them good surgery, you remove the tumor, they do have much better prognosis. The only requirement I always ask is the absence of metastasis. So if there are mets anywhere, we do not operate. But if, regardless of the invasion, even if it reaches the atrium, and we've done that, it doesn't matter as long as there is no metastasis. This is one such case where there's a very, very large renal tumor, RCC, and invading the cava intrahepatic, and it's going, all the way to the diaphragm. This type of surgery needs a total hepatic rotation, so you can control the cava in whole, and you can expose the hepatic veins as well. It's quite demanding. I usually do a lower median sternotomy as well, and I like controlling the supradiaphragmatic IVC to prevent embolization, and that would be very temporary control. I always warn my anesthetist before I do that vital step, because once you have the control of the cava distally, the supradiaphragmatic cava, the tumor is sort of dissected out, the liver is rotated, you're ready to clamp the cava, the venous return will drop and the pressure will drop, and that's why the anesthetist should be on board. And there are the special maneuvers we give them. Speed is vital with these surgeries, so that as soon as you've removed the tumor and the thrombus, the tumor thrombus or the invasion from inside the cava, you need to restore blood flow. And the supradiaphragmatic IVC control I found extremely helpful in preventing embolization to the heart, because these can easily embolize and they get you into trouble with the patient, obviously systemic condition. That's what we've done in this case, and you can see that the tumor is removed with the thrombus invasion all the way to the diaphragm. Similar tumors happen in pediatric age group. Pediatric malignancies, the Wilms tumors, there are two main kinds, the Wilms tumors and the neuroplastomas. The Wilms tumors, they're usually lipulated tumor masses, encapsulated. They have a mixture of immature cells in histology. The good thing about these tumors is the massive impact you will have on the child's life when you do the procedure, which is a combined chemotherapy and surgery, and you give the chemotherapy before to reduce this, try to shrink the tumor as much as you can. The 5-year survival will be about 90%, and the younger the child, the better to do the surgery. They do get better results when they're less than 2 years old. A similar tumor is also the neuroblastoma. This is one of these tumors. I also use the median sternotomy and the Mercedes type incision for these for maximal exposure. You cannot compromise exposure in these patients. You have to be very comfy with your procedure. Liver mobilization is complete so that once you get the tumor, and this was invading all the way to the diaphragm as well, then they usually have a very fibrotic type invasion into the cava, but you can get it off the cava. If it's very adherent, it's better to excise part of the cava, and if it's less than 50%, you can patch it or replace it. Another group is the adrenal and extra-adrenal tumors. These are usually very difficult because of their location. This is one of these tumors where it was located right at the confluence of the renal artery, the aortic renal artery bifurcation or branching, and the renal vein butting into it. And if you do the adequate dissections, you can get these with preservation of all vital structures. It's important to establish there are no myths with these, because they can go into lymph nodes, adjacent lymph nodes, and if on histology it appears there is invasion, you probably should go back and clear it with para-aortic dissection. I did get special interest in limb salvage in vascular surgery, and part of that we started getting referrals with limb salvage with bone tumors. And these are very satisfying surgeries to do as well, because again, this is a younger group of patients. There is a lot of literature these days about limb salvage, especially with advanced joint and limb replacements. They're doing amazing with these amazing modern joints, where you can remove a whole knee, a whole shoulder, and you replace it for a child or a young man, and you preserve their limb. In the sarcomas especially, it's no more, if the limb is affected, the limb goes. You can do a limb salvage, limb preserving surgery. This is one example of such cases. The incision you see is a typical of these patients. They come in with the incision which was done for histology, for histological confirmation. And it's important to know where they've taken the histology from, because in your surgical planning, you should excise that incision and the area adjacent to it with the surgical excision. In these patients, frequently they're invading into vessels, either popliteal or femoral vessels, and I usually sort of do the bypasses first, leave them a bit long, so patients will not get ischemic during the excision, do the excision, and if I need to shorten bypasses, that's what I do. This is one example of such cases. I've done both the arterial and the venous anastomosis or bypasses, then went in to remove the tumor. As you can see, they're long a bit, and that's intentional. Once you put in the joint, the knee joint, then you measure it up. If they don't sit appropriately, then you can always shorten one of your bypasses with a simple primary anastomosis. A shoulder, this is a shoulder case with a sarcoma as well in a young child. And, I've told you previously, you get these amazing prostheses these days, and you can completely replace the shoulder girdle. We've done also a bypass with these. It's not just the bypasses with these, it's also the assistance for your orthopedic colleagues for the proximal controls, which was in this case very proximal, axillary subclavian control for both the vein and the artery, and the dissection control, the dissection assistance. And they very much evaluate this. And to be honest, once you take the program off the ground, you start gradually give the skills to your orthopedic colleagues, and some of the simpler cases, or the cases that do not need anastomosis replacement, they will do themselves as well. So to give you just a general idea of our experience, so we had 66 head and neck paragangliomas, other ENT tumors, which also, and a lot of these get referred by the maxillofacial surgeons. They also invade into vessels, and you need to replace these vessels. Unfortunately, I did not have the images to one impressive case I should have shared with you, which I've done during my practice with the military in Afghanistan, where it was a massive tumor invading the lower jaw and invading the vessels. And, we could excise the whole thing with replacement. It was great fun to do. Thoracic tumors, we had 3 mediastinal tumors, renal tumors, 18 of those, adrenal, extraadrenal, 3 of those, limb salvage, 22, and retroperitoneal tumors, 17, and 5 other tumors, including the abdominal wall tumors. And these very interesting, actually, to be honest, because they do mimic vascular anomalies, and some people misdiagnose them as, AVMs, but in histology, you find these are some sort of low malignancy sarcomas. In conclusion, there's a multidisciplinary teams are essential for this sort of practice. You also need tumor boards because, you cannot, the decision should be collective. As always, you should get oncologists on board and involved for the adjuvant therapy or for the post-operative follow-up as well. Outcome measures and long-term follow-ups are essential as well. I leave you with this quote from Sir Robert Hutchinson, which is I greatly admire and I use in my practice. It's a prayer: from inability to leave well alone, from too much zeal for what's new, from treating patients as cases, and from making the cure of a disease more grievous than its endurance, good Lord delivers. Thank you.
Great. Very nice, very nice. I like it very much.
Oh, thank you, Dr. Amir. You're so kind.
Thank you, really. It is very nice presentation, very nice topic, very nice illustrative cases. I have just 2 questions. First, for such unique surgery, what's your protocol for anticoagulation?
So it's a very important question, Dr. Ayman. I treat the vascular problem. So to be honest, I'm aggressive anticoagulator. So I anticoagulate patients even before I start cutting. So I do anticoagulate him as soon as we get into the tumor, or into the cavity, the abdomen, limb, whatever it is we're operating on. I do not worry about the side effects of anticoagulation with the bleeding. And one thing that comes a bit with experience is speed with surgery. Speed does not mean doing things hastily. You have to have the important steps done correctly. But once you do, long procedures, hypothermia, all the other things that cause bleeding, that's your enemy. It's not the anticoagulation. Anticoagulation is very important, and what's important also, I emphasize, is anticoagulation post-operatively. So you keep these patients, because these are malignancy patients, so you keep them on full anticoagulation while in hospital and on prophylactic anticoagulation while at home, at least for 6 weeks. And I can never forget one patient that unfortunately we lost on the day he was discharged because of a PE, because he wasn't taking, we thought he was, he was given the appropriate anticoagulation and he apparently wasn't taking it. So anticoagulation is extremely important.
Okay, that's what exactly I want to hear. I think Dr. Sergio want to make a question. Please, Dr. Sergio.
Sure, and sorry for having missed part of this, but I had to take my ride home. If not, I was staying in the hospital forever. But I really enjoyed part of that. And I have a simple question for you, Mamoun. You're, of course, like a top expert in the field. And we have recently enjoyed an editorial from Mansila on the shifting in the training of the residents in vascular surgery that are not like so much exposed to open surgery. So do you have some comments on the training of the new generation of surgeons that are so used to endovascular procedure and maybe less to open surgical ones?
Well, thank you for bringing this up, Sergio. And I think it's a vital topic that a lot of us that are involved with training and with sort of on the international scene when it comes to certification and training. And in the Middle East, one of those regions that we're working hard on guaranteeing that future vascular surgeons are adequately trained in both fields. It's a problem that all specialties are facing, to be honest, but none is so obvious than vascular surgery, because we are getting to, even with a simpler what we consider simpler vascular procedures like aneurysm repairs. We're getting to a stage where, a trainee would probably see very little or no open aortic repair in his practice because everything is done endovascularly. When it comes to this sort of surgery, I cannot emphasize enough that our trainees should be involved with large surgeries, or sort of meaning large, being aggressive, where they go into all parts of the body, because when they're asked for their expertise to save a life or to rescue a colleague from bleeding somewhere, they should be able to do it regardless of the anatomical area. How do we achieve that? It's open to question and debate, to be honest, Sergio, and I think international consensus should come into the certification of surgeons before we let them loose, with the practice, what sort of skills they should have when it comes to operating open operation. We've done some work with simulation and training surgeons on the virtual world. It is never a full adequate replacement to the real world, because they need still to do these surgeries.
And do you think, Arun, that it would be possible to create a sort of certified centers where residents can be sent, so that you maybe set out some parameters of a certified centers for receiving this?
Absolutely, I couldn't agree more, especially now that we all come to the realization of the agreement that certain procedures should be done in high volume centers. And the more you sort of make these cases, send these cases to these centers, the less the other hospitals, the training areas will have them. International cooperation, I think, is vital, to be honest. And we're looking a while ago with an international program. I've been lucky throughout my practice that I've practiced vascular surgery and transplant in 5 out of the 6 continents. So I've worked in many countries, Canada, New Zealand, England, etc. And we've worked on this program where you have an international exchange for trainees. There are a lot of obstacles, and I think the only way to do it, to be honest, is to do it through the main surgical bodies, be it the colleges, be it the societies, the major societies, or an independent training, organizing facility. But this would be the ideal thing for the future.
Congratulations, thank you so much.
No worries.
Okay, Ma'moon, this is nice. And we have many questions for you. I see Dr. Mahmoud Salah is raising his hand. And do you want to ask the question yourself, Professor Mahmoud?
Yes, can you hear me, Dr. Ayman?
Yes, sure, please.
Yes. Ma'moon, amazing as usual.
And then now it's all my good friend, Ahlan Sahlan, Dr. Mahmoud. How are you, sir?
Wallahi, missing you so much. It was
camera so we can see your nice face, Mahmoud.
Allah yakhalli. Fantastic talk, Ma'moon, and I like very much when you said about the liver tumor that you need just to repair the portal vein and inferior vena cava, as if something very easy. I can assure you many close their career without seeing the portal vein. But anyhow, just not to take much time, I want to ask you 2 questions about the carotid body tumor. Sure. When you have to sacrifice the internal carotid during this surgery, what is your first option to replace the carotid, whether the external carotid or artificial graft or vein? This is one question. And the other question, what would you do for bilateral carotid? And you do with 2 stages or 1 stage, and how much space?
Thank you, Mahmoud. Excellent questions. A replacement, I always use vein grafts. And in all cases, we preoperatively map the veins so we know exactly if I need a vein, where to take it from. And it's usually the proximal long saphenous in the thigh, and it's prepped and draped, ready to go if we need it in all cases. These patients are usually young, and I don't like using prosthetic for replacement, well, for multiple reasons, but the vein grafts are excellent. The external carotid, I do not replace. So if it's excised, it's excised, it's done, especially in unilateral cases, and they rarely get any symptoms from that. In fact, with the surgical maneuver, you use the external carotid as a handle and you excise it early so you can move the tumor around while you're operating. And it's a good trick and technique. And you know, a lot of the carotid body tumor supply will come from the external carotid, in addition to occasionally, which is the Meidels ligament from the common. But you know, once you excise or clamp the external carotid, the supply will shrink as well, and that will help the surgery as well. When you get bilateral carotid body tumors, it's a staged procedure. So you do one side, make sure there are no complications with them, and you know, at least 6 weeks later, you do the other side. There is no hurry. These tumors are benign, slow growing, and the patients, you know, they're happy they're diagnosed. You can plan the surgery at your leisure. The only thing, not to leave them too long so that they change their Champlain classification, but we never do them at the same time.
Thank you very much.
We have a question from Professor Tariq Abdulazim. Professor Tariq, one of the most eminent vascular surgeons, and he is also the head of the vascular department in Ain Shams University, one of our biggest universities. Please, Professor Tariq.
Thank you, Omar. Thank you, Dr. Mamoun, for an excellent presentation. I just have a comment and a question. The comment is, I fully agree with your policy regarding preoperative embolization for carotid body tumors. We have not found that to be helpful at all, like you mentioned, and it doesn't really seem to decrease the vascularity of the tumor intraoperative, plus the fact that it does, as you have clearly mentioned, have its own share of complications. So I agree fully with you regarding this point. My question is about renal cell carcinoma patients that have extension up through the IVC and into the right atrium. What's your sequence for dealing with these patients? Do you open the chest first and have the cardiac surgeons put the patient on bypass first and then do the abdominal part? Or do you start with the abdominal part with some risk of something embolizing upstairs? Thank you.
Thank you, Tariq. That's a great question. Now, we had a couple of cases with right atrial invasion, and we've used 2 methods with them. One with complete cardiac arrest, hypothermic arrest, obviously a cardiac surgeon colleague on board with that. And what we've done, we've opened the abdomen, done the initial dissection of the tumor. So when you're ready for the excision, you're ready to go, and it doesn't take much time, because that's where most of the time it's going to happen. It's the hepatic rotation, it's the obtaining controls of the vessels, it's rotation of the tumor itself. So when you're ready to go, you open the chest, go on to hypothermic arrest, and then you can open the atrium, extract it, and do. To be honest, I did not like that at all. The surgery in that case did not go that well, not because of the surgery itself, because of the post-operative coagulopathic complications. And although our arrest time was very short, they did get into massive coagulopathy. The other one is we've used a different maneuver, which is keeping them sort of off pump all the time until we're ready to go with the removal, and then we put them on pump temporarily just to open the atrium and back to, once you close the atrium, opening the atrium, removing the clot is so quick and so fast, it doesn't take much. And I prefer this method to do. We had one other case where the embolization happened intra-operatively from manipulation of the tumor of the cava, and that's before I started using the slinging of the supradiaphragmatic IVC. And we found that on, doing the echo, the transesophageal echo, then we had to go and pump and open the atrium and remove the tumor. So that would be the appropriate technique, in my opinion. The section of the tumor ready to go, then you open the atrium, remove the tumor from the atrium, and by which time you excise the abdominal tumor.
Okay, thank you very much.
No worries.
Thank you, Dr. Tari. It was a very good question. And it must be answered very clear, as Dr. Mamoun said. Now I think, Omar, we all thank Professor Mamoun and our panelists. I think this is time for polling question, Omar.
Yes, it's time for polling question, and I would like to welcome Professor Victor Canata and like to invite him to the panelist. He's attendee, so he can join us as a panelist, and then we're ready for the second poll. Okay, the second poll: how long do you recommend the post-interventional use of graduated compression stocking after endovenous laser therapy? How long do you recommend post-intervention use of graduated stocking? A, for 1 week or less, B, more than a week, or C, not at all. And I would like to extend my thanks to Sigvarus Group for sponsoring our webinar. So if you can select which one do you use and submit your question, we usually get 20 to 30 seconds for the result, which will be, to me, will be very interesting, especially as a preparation for the next great lecture by Raul from India, one of the most eminent laser venous therapists worldwide. So can we see the result of the poll? Oh, hello. Welcome, Raul.
Hi. Thank you. Hi. Hello. How are you?
Hello.
Fine, not too bad.
Hi.
So, 70% said more than a week, and 27% said 1 week or less, and only 4% said not at all. So it's back to you, Professor Ayman.
Okay, that's great. Expected answer. Thank you. Now I am honored to welcome Dr. Victor Canata from Paraguay and Dr. Javier Serlet from Mexico joining our panel. It's a great honor for us. And now it's time to welcome Professor Raul Jindal, the Director of Vascular Clinic of Fortis Hospital in Mohali, India, Chairman of Governing Council and past President of Venous Association of India, Executive Member of International Compression Club, member of the Education Group of the UIP, Treasurer of Asian Venous Forum. Thank you, Raul. And now he is going to discuss one of the most important hello, Raul.
Hi.
He is going
I can
basics later in varicose veins treatment. The mic is yours, Raul, please.
Thank you, and good evening, and welcome, and to all my friends from all over the world. I'm really sorry I got stuck up at an iliac rupture, so I had to rush from the hospital. So I just came home, so I'm slightly in the hyper mode, so I'm really sorry for that. But it's a very important topic, and you know, there are very important things I really want to discuss. And I was speaking to Sergio in the afternoon, and you know, I asked some help from him also in the evening. And I'll start this topic, and I'll cover it in two topics. two parts. One is the basics of laser physics, which I see as a as a phlebologist or as a vascular surgeon. We must know the laser physics, because sometimes I hear these questions being asked on our forum. What should we use, an ND-Weick laser? Should we do 980? Why should we use 1470? Should we use 1940? A lot of these questions are being asked. But, we must understand really the basics. Then you will be able to answer all these questions in one go. So that's why please don't get, bored with the physics, but it's very important. I've tried to make it very simple. You'll be very surprised to know that laser started in Egypt. So Egyptians were one of the first guys, which has been reported that they used the lasers, and there has been used in the treatment of vitiligo. After that, there have been a lot of people who have been trying to use the laser in different indications. So what is laser? Laser stands for light amplification by stimulated emission of radiation. So how is it different from the normal light? You see, if you look into the laser, I put in some diagrams. On the left side, you see it's monochromatic. What that means is, so as you know, each light goes through the prism, makes a rainbow. So it has only one color. Second is, it's unidirectional. So it will go only in one direction. So it will not like a light bulb or the tube, where the light goes all around. And second is collimated, means all the beam will be parallel. It will not be non-collimated. So it will not be go like this, it will be all parallel together. So this is a very important difference between laser and other lights. So important to understand is, how does the laser get generated? Because we hear ND-Weick laser, KTP laser, all those lasers. But what's the difference? So laser is, on the top, if you can see this diagram, so there is a high voltage source outside the tube. So high voltage source could be anything. It could be a chemical, it could be a diode, it could be another laser, and it could be anything which will excite the atoms which are present inside this gas discharging tube. So now this tube can contain anything. What we call is an active medium. So if you have a solid crystals, it's called as a solid laser. You could have a liquid like dye, what we call dye laser. You could have a gas inside this, like a CO2, helium, neon. Then you will say CO2 laser, helium laser, neon laser. You could have an ND-Weick. ND-Weick has two components. One is solid component and one is a liquid component. So combination of solid and liquid, then we call it an ND-Weick laser. You could have a diode. What we say a diode laser, 8110, 980, 1074. So all these things all depends upon what sort of an active medium you use in the tube. All these active medium can be excited by an external source. So once the atom gets excited, all the electrons will go on the top, they will be excited. And once they come back to a normal stage, they release what we call as photons. It's a very simple thing. So they will release an energy. So when they release the photons, they have to strike somewhere. So in this tube, we have got one side, a complete reflector. So the photon will go and strike the reflector and come back again. And there is only a one output, what we call as a partial reflector, from where the laser will go out. And we can actually select what sort of laser can go out. Example, if you put an ND-Weick medium inside the tube and we excite it, you know how many lasers can come out? It can give you around 7 to 8 type of lasers which can come out. But we can choose what we want. So we can also use an ND-Weick 532. We can use an ND-Weick 1064. So if we can choose what sort of wavelength we want the laser fiber to come out. So there is a technique to do that. So this is how we produce the laser. So, very basic thing to understand. So this is, I've just explained, once the excitation of the atoms is there, so they all get reflected in between each other, and then they come out from one hole, a laser is taken out. Now, once you understand this, then once the laser comes out, it interacts with the tissues in different ways. So basically 4 different ways. One is it can reflect. Second, it can scatter. Third is it can transmit through the tissues. and fourth is the absorption. And for us, the two important things is the transmission and the absorption, which is very, very important. By which all these four methods, it will cause you either a thermal reaction, it will cause you chemical reaction, or it will mechanically damage the tissues. So all these things, we take the benefit out of it. Now, chromophore is very important to understand. You know, all these company guys, they keep on telling you, now 1470 is coming up, now 1940 is coming up, because it gets better absorbed by the water. So there are basically four chromophores by which all near laser works. One is the melanin, hemoglobin, water, and the tattoo inks. So we play around with these four chromophores. So you have to understand, it's very straightforward, simple thing. So when we look into the laser types where tissue effects, so it could be an ablative and non-ablative. So it's very self-explanatory. If you are ablative, it's very strong, like a CO2 laser, and it will just take the tissue off. Non-ablative lasers are very soft. So they will heat the skin, but they will not damage the tissue. Now, this is a very important spectrum to understand. You know visible light, and you know the mnemonic VIBGYOR means all the visible light spectrum. So that varies from 400 to 700 nanometers, so which is there in the center. So on one spectrum, on the left side, we got VIBGYOR. V means violet color. So anything below this will be an ultraviolet. So below it, ultraviolet. And below that will be an X-rays, gamma rays, and cosmic rays. And ultraviolet rays are further divided into ultraviolet ray A, B, and C. And these are shorter wavelengths. But when we go to the right of the red, right of the visible spectrum of the red, is called infrared because it's below the red. So it's called infrared. So when we call near infrared, middle infrared, and far infrared rays. And below that, we get microwaves, radar, radio waves, and all. So this is very important to understand this. So when we talk about 810 nanometer, the first laser, what we use in the practice, that falls near infrared. As you can understand, it's an 810 nanometer. So it's a near infrared rays, which we generate. When we talk about 980 nanometer, which we use the second laser, so we call about near infrared. Then we go to 1074 NDY, which we use for cosmetic lasers, for the Clark's technique. So that goes also the infrared. Then we go to 1470, which we use the laser in the varicose veins. That falls into the far infrared. So that's how the spectrum works. So if you look into this spectrum, so it's a very, very important slide. So you look into this, in the visible light, you got a lot of lasers which are there. Argon, Andy-Weick 532, dye lasers, alexandrite, ruby, all those lasers. These lasers, they all are very superficial lasers. So they don't penetrate deep. The reason is because they've got a shorter wavelengths. So in the visible spectrum, all these lasers, they have got shorter wavelengths, so they cannot penetrate deep. The higher the wavelengths you go into the infrared spectrum, you can see Andy-Weick 1064, Andy-Weick holmium laser 2140, erbium laser, erbium-Weick 2900, CO2 laser, which is the biggest, 10,000 nanometer. So the depth of penetration increases as the wavelength increases. So that's very important. So that's why people ask, why don't we use KTP laser or the dyed laser for Clark's procedure? You cannot, because the vessels are deeper. So you need to use a longer wavelength laser. There are other reasons for that also. I'll come to that. Now, this is a very important spectrum to understand. Look into this. You got in the visible spectrum, 400 to 700 nanometers, you got maximum absorption of HBO2 and melanin. So where is the water? It's not there. Okay. So if you are working on this spectrum, there is no water absorption by any lasers. Now look into this. It's very important to understand this. Look into that, the black line, that's a melanin line. So as the wavelength goes up, the melanin absorption goes down. Hemoglobin absorption goes down. And look at where does the water absorption starts? After 900 nanometers. So we used to use 810. That was the first diode laser which we used to use, and still it used to work. it used to have 94 to 97% occlusion rates. So how does the 810 nanometer laser work without water coefficient? Okay, so it used to be absorbed by the hemoglobin and still it used to work such a good closure rate. So what's the problem? I'll come to that later on. It's very interesting. So if you look into the KTP diode, all those lasers, so they work on this spectrum of 3 chromophores, which we talked about: melanin, hemoglobin, and the water. So that's the basic concept. If you go higher up, if you look into our let's say what we are interested in, let's look at NDY 1064. Look at the spectrum of water absorption. It's very low. The water absorption is just started, but we still use NDY for the cosmetic reasons, because we want the maximum absorption into the hemoglobin molecule, not into the water. So that's why we are using this. I'll tell you later on as you keep on going. So now this is a chart which is given by the companies. What that means is that if you use 1470 nanometer, you get less water absorption. So that's why I use 1940 laser, a new laser, because it has got more water absorption. But at the same time, it has also got hemoglobin absorption also, HbO2. So this was another chart which was given that if you use 1470 as compared to 1940, 1940 get 4 times more water absorption of the laser. So that's why we should use 1940 instead of 1470. So this is how we make the NDY laser. You know, this is a lasing tube inside, and we put in the solid component called yttrium, aluminum, and garnet, and we combine it with a chemical agent called neodymium, and we activate it through any route. You know, as I told you, you can use anything, and then you can get various types of laser out of it, and then you can select what sort of laser you want for your machine, so for the treatment. So there are machines by which you can modify this, the same component, and you can get 1064 also, and you can also get 940 nanometer laser from the same machine. Now coming to NDY, why I'm talking about NDY is because we use it for the Clark's procedure. So I'm covering the superficial and the deep veins both together. So it uses a lower power, offers high gain, it has got good thermal properties, good mechanical properties, and efficacy of is very high as compared to ruby laser. Remind you, ruby laser was a very strong laser in the visible spectrum, somewhere around 500 to 600, and it's very strong, but it's very superficial. Coming to the basic terminology. Now these 5 words we have to know, and that's why it gets confusing, but they are very simple. So wavelength we have already learned, you know, we have already covered it and how it works, but we'll learn slightly more about it. Then the fluency. Fluency is the energy, then the pulse width, thermal relaxation time, and pulse repetition time. And all these 5 components are very important if you want to treat these patients. I'll go one by one. Coming to the wavelengths. If you have a shorter wavelengths, like in the visible spectrum, it has got less depth. And photons carry a lot of energy. So that's why if you use a visible spectrum lasers, there is a very high chance that you will burn the skin. If you have a longer wavelengths, it penetrates deep into the tissues, and photons carry a smaller proportion of energy. The chances of complications are much lesser. Now this is how it works like. So if you look into totally the center, our area of interest, NDY 1064, it goes very deep and it can reach into the reticular veins area, and it can reach into the, you know, the dermis area, and can treat all that telangiectasias which we require it to be treated. Similarly, if you look into this, the depth of penetration increases as the wavelength increases. Coming to the fluency. So what is fluency is? Joules. Joules is the amount of power which we want from the machine. So in terms of wattage, like we want 8 watts, we want 9 watts, we want 10 watts. So how much energy you want to be delivered to the tissues? And if we say we want to deliver 10 watts in 1 centimeter area, that gives you joules per centimeter square area. So that means a fluency. coming to this concept of leads, or we have all heard about leads, that we should keep the leads like this and this. There are a lot of publications which are against the leads, and they say it's really effective rather than the total energy given. I'll give you an example. Let's say we want to deliver 10 watt of energy per centimeter. So we say 10 watt given per centimeter. And so how much is that? Fluency is 10 into 1, 10, 100. And so let's say we give the same amount of energy. We want to give 10 joules. So I just decrease the amount of energy to 0.1 watt and give it at 0.01 millimeter distance. The time will be more, the energy I have reduced, the distance is the same, but it will not produce the same effects. So if I calculate the lead will be the same in both the categories, but the total energy delivered will be the same. So leads will be the same, but I will not get, if I burn the vein at such a small energy in that whole centimeter area, the vein will not get closed. So that's the drawback of the leads. So people who are against the leads, so they put in this justification. Coming to the pulse, is in that particular time, in that laser beam, when it fires, and how much pulses you want to give. If you want to give the pulse in milliseconds, you want to give in nanoseconds, or you want to give in picoseconds. The difference between this is, if you want to give the energy just like that, it becomes a picoseconds. I'll just explain that. Coming to the pulse duration, so the amount of time you want to deliver the laser energy to a particular point is called pulse duration. And this is very important because you can have a smaller pulse width and a larger pulse width. So why it's important is, this is because of this. Because you can give, if you have a shorter pulse width or you want a longer pulse width. It's very important because the pulse duration, any laser you want to use, it must be less than the thermal relaxation time. So what is thermal relaxation time is? So let's say I'm giving the laser energy to the skin, and what I want to burn, let's say a small pigment which is there, but I cannot give a pulse duration too high, otherwise I will burn the surrounding skin. So I have to give the pulse duration only up to that time, unless that skin which gets heated, it also gets relaxed at the same time. So every molecule, every chromophore has got a different thermal relaxation time. So this is a very important chart to understand this. Leave the melanosomes and the cells, look at the blood vessels where we are interested. So let's see, you are treating a 200 micrometer diameter vessel, telangiectasia. Thermal relaxation time for that is 20 milliseconds. So you need to keep the pulse width on your instrument less than 20 milliseconds. So maybe around 15 milliseconds. If you are treating the diameter 500, the TRT is more. So you have to use a less, you can increase the pulse width a bit more. So you have to keep the pulse width below the TRT time. Next is the spot size. Smaller the spot size, smaller penetration. Larger the spot size, you get more penetration and you can cover a bigger area, so you can treat the treatment faster. So if you have a very small vessel, you can keep the small spot size. Larger vessel, you can keep a larger spot size. Now this is a very important slide. I really like it. It's a WTF. You can understand what it means. What it shows is, on the left side, if you have a shorter wavelengths, if you keep shorter wavelengths like a KTP laser, visible spectrum lasers, as we discussed, it will be superficial. Short pulse width will be superficial. Small spot size will be superficial, and low fluency. Low fluency means less wattage, because you don't want to put in too much energy. Longer wavelength will go deeper. Longer pulse width will go deeper. Larger spot size will go deeper, and higher fluency will go deeper. So this is how we choose. So if you have a superficial lesion, you choose the left side. If you have a deeper lesion, you choose the right side. So achieving the optimum is, you have to select three things importantly. One is the wavelengths, what you want to treat. Second is exposure duration. And third is the fluency, how much energy you want to damage that tissue. Now, this is one of the last slides of this spectrum is, you can have a continuous spectrum of laser, so where the beam is fired continuously. So it really produces very high power. Then you can have a pulsed laser, where higher energies are given for a shorter duration pulse. Then another system is in the newer machines is a Q switch. A Q switch is extremely high energies which we use, but for very small pulse. And then we have a Q switch at the picosecond, where absolutely shorter pulse durations are used. Now, why I'm telling you here is the Q switch is very important if you want to use it for post-sclerotherapy pigmentation. So you can use its technology because you get this pigmentation there. You can use a picosecond or nanoseconds NDYAG 1064 laser to take these pigments out. Let's say leave this. Now coming to the endovenous laser, you want me to stop here, Dr. Ayman, or I can't hear you, sorry. Okay.
Yes,
yes, we can take a break to take a few questions, yes.
Yes, I think it is very important and very nice presentation, very basic, and I think we'll have many questions because it is very hard to understand. I think
Dr. Ayman, you know what is happening? This was the basics, because now all this will be applied in the clinical setup. So,
yes, it is.
So I was thinking of completing the lecture, because then people may be asking the questions which are there already in the lecture, because I'll be applying all these basics now into the clinical setup.
Let me check who is raising his hand.
Okay, fine.
We have 3 questions, but they can wait until the next part. Raul, I know this is the preparation for his next part, and then we can take question at the end.
Okay, let's the second part.
Okay.
Go on.
Thank you. Now, you know, this was a study, I got it. You know, it was Sroka et al. Published in 2013. It's a very important study. This is one of very few studies published where they have done the comparison between 980 nanometers, 1470, and 1940 nanometers. So in our setup, we are using all these 3 lasers. You know, actually I started with 810, but then moved to 980, then 1470, and we have 6 months we have been using 1940. So you look into the basic diagram which they have put in the histological. So I'm just presenting his study. So what I have shown is that where in the first 980, we were using higher energies. So we were using the leads of 150 or 130 joules per centimeters. And we used to have more carbonization, more perforation. Then we moved to 1470, we used less leads, maybe 60 to 70 joules per centimeter. You have a circular thermal alteration. Then we moved to 1940, we use much lesser energy, 30 to 40 joules per centimeter. You get circular thermal alteration with vacuolization. So less damage to the vessel, more damage to the vessel up to the outer part of the media or the adventitia. Sorry, just a minute. What happened to it? So he did 2 trials. One was he used the 1940 radial fiber with a higher energy, 4 to 9 watts, with a continuous pull-up, and put in the joules of 40 to 90 joules per centimeter. And it compared to the other trial where he used a lesser energy, 2 to 4 watts, and where he used a lesser energy, 20 to 40 joules per centimeter as a leads, and around 150 patients were there in both the groups. So this was the setup, radial fiber of 600 micrometers, you know, at the Bing, and post-operative patients were evaluated at 6 months, 1 year, 2 years. And they looked at the basic, all the setups like stump lengths, vein diameter, seep, and the safety profile and all the drawbacks, what we all know. The important thing is they found that at day 3 and 6 months, the occlusion rates were on 98 to 100%. Recanalization with reflux was 0 to 1.8%. And reflux in ASSV was 0 because it was sort of a laser crossectomy. And you know, various seep classifications were involved in this group. And if you look at the basic side effects, pigmentation, ecchymosis, phlebitis, they were all very, very small numbers, 1 to 2%. So not much drawbacks. And I think if you look into a lot of 1470 trials, they have got the similar outcomes. When we looked at the pain score and taking analgesics and analgesics, so they were very basics. So they were not very huge numbers which were involved. And when we looked at all the 1940 literature which has been published, if you look into these publications which are there, so they got various numbers which are there, level of evidence, and they all show a very good results, at 6 months to 2 years follow-up, and it shows 96, 99% closure rates. So all the conclusions are it's effective, safe, high patient comfort, reduced laser power, and further follow-up and more clinical trials is required. So as we used to have by 1470. And all these publications, they say, so future is longer wavelengths, 1940, maybe a bit more because the water is going up, as I showed you. Reduced power, more reduced power, reduce the amount of tumescence, radial fibers, standardization of treatment protocols, slow continuous pullbacks, and shorter stumps. So this is what we think. So now I put in 3-4 slides. So when I went to all the literature and whatever knowledge I had, so there were a lot of things which I could not understand. When we look into all the publications published on endovenous laser therapy, we still don't know how the laser therapy closes the vessel. There are basic 5 mechanisms which has been published in all the publications. So one is the bubble theory. What that means is that at the tip of the fiber, there is a carbonization. And when there is a mild carbonization, the tip of the laser fiber, the temperature increases up to 100 degrees centigrades. And once the temperature reaches 100 degrees, it produces bubbles. And these bubbles, they transfer and travel and cause the heat dissipation to the vein wall. You see, the basic concept in endovenous laser therapy is we want that the vessel wall gets damaged by the heat and it gets fibrosed and it gets closed. So that's a basic aim. So how does the heat goes into the vein wall? So one is the concept is by bubbles. So bubble travels approximately 2 centimeters proximal towards the foot side up the laser fiber. Second concept was the direct contact. So this was the first concept of endovenous laser therapy when we were using 810 nanometer, that the laser fiber closes the vein by direct contact, because at that point we were using the bare fibers. So the bare fiber will contact the vein wall, it will heat the vein wall, and it will get damaged. Then came the concept of blood coagulant. What that means is there is a blood in the vein, you cannot empty the vein fully 100%. And as soon as you fire the laser, the blood gets coagulated. So you get a thrombus formed there. It got a lot of heat, and the heat from the thrombus, the hemoglobin part, gets to the vein wall, and then the vein wall gets destroyed. The fourth concept was a heat dissipation, means from the laser fiber itself, from the tip, the heat gets dissipated into the vein wall. And the fifth concept was the carbonization. What that means is, this is one of the basic concepts, that all the laser fibers will get mild carbonization at the top, resulting in increased temperature of the tip and resulting in a heat dissipation from the carbonization into the vein wall. And the sixth concept which is there is that where does the laser energy gets absorbed from the laser fiber? Is it gets absorbed into the water molecules, or it gets absorbed into the hemoglobin molecules? As I told you before, 810 nanometers does not have a water absorptions, so it still blocks. Second, a lot of publications are there that the heat gets, the blood has got more than 60% component as a water. So the most of the heat from the laser energy will get absorbed into the blood rather than the water in the vein wall. So there have been few studies which shows that the laser energy gets absorbed into the water of the vein wall directly. So if you look into a lot of physics, doesn't make sense. If you look into a lot of publication, it doesn't make sense. So according to me and according to all the literature what I've gone through is that the heat rarely goes directly into the water of the vein wall. Unless you totally make the blood, the vein totally bloodless, then that may be the issue which is there. So that's why a question that 1470 laser or a 1940 laser, will it going to make a difference? I really don't think so. So what wavelength? Because really water is important, because we don't know exact mechanism why the vein blocks. So there are 4 to 5 mechanisms, and a lot of publications are there on each one of them if you go into detail. So really, what wavelength you should use, it doesn't make a difference. Yes, the type of fiber, it makes a difference. Then there is a study published where they showed that the carbonization rate in all the laser fibers. So what that means is, you take up any laser fiber, there will be a small layer of carbonization, which is seen by a microscope on all the laser fiber tips. What that laser carbonization does it, as you know, if you take the laser fiber and put it into the air and put it on or into the water, the temperature at the tip of the laser fiber does not increase, it's nearly zero. And if you put this laser fiber into the blood component, the temperature goes to, with a mild carbonization, to 100. But if you get a proper carbonization at the tip of the laser fiber, the temperature can go up to 1000 to 1200 degrees centigrade. So very high temperature can be there at the tip. But small carbonization, which happens in the top, puts in a lot of heat at the tip of the laser fiber, that dissipates heat. So this is one of the basic mechanism for damaging the vein. Now coming to the fiber types, bare fibers, radial fibers. Yes, as compared to the bare fiber, radial fibers are different, because radial fiber, the heat is dissipated equally all around and in over a period of segment of 1 centimeter. Maybe that's why it gives you a better closure, but we still don't have a theoretical or a full proof about this if you look into the physics. If you look into superficial lesions, why Nd:VAG? As I told you, it's a stable laser, depth more than other lasers. It targets both hemoglobin, which is present inside, and also target the myoglobin, which is present in the vein wall, and also the water. So why not the other lasers? They're very strong, as I told you. They're very superficial, but they can be used for facial veins. There is a basic difference between facial veins and the varicose veins. If you look into the facial veins, the diameter, if you look into the vein wall, the diameter of that vein wall is not the diameter, I should say, the width of the vein wall is approximately 5 to 10 micrometer. If you look into the varicose veins, it varies from 50 micrometers to 500 to 600 micrometers. So the facial veins are very thin and they're very superficial. So we can use the KTP over there as compared to Nd:VAG. Now this is very important. If you look into this, I don't know if you can see the chart. Selective photothrombolysis by Nd:VAG. So 1064 is selectively absorbed by HPO2 and HP much more than the water. As I told you, if you look into the water molecule, in the beginning only the 1064 molecule is there. So that's why if you are treating the plaques, there should be a blood in the blood vessels. So in the telangiectasias or in the spider veins, there should be blood present there, because if there is no blood present there, the results will be bad. So that's why if you are using the coolant system along with it, if you put in the coolant system for a very long time, the vessels goes into spasm, the blood disappears from the blood vessels, and you will not get good results. So here it's opposite. You want the blood to be there in telangiectasias, because that's how the 1064 is going to target. It does not target anything else. Another why we use this is because it has got more depth. And second is, it does not get absorbed by the melanin, very low component. So that's why, so you will not get much skin damage, especially, in the type 4, type 5, type 6 darker color people, because they have got a lot of melanin. If you use the previous lasers, early lasers, KTP and all, they can be absorbed mainly by the melanin because of the melanin curve, which we discussed. So at the wavelength of 1064, melanin is a weak chromophore. So we got higher safety margins are there. And that's why we can use a higher energy so that we can damage the blood vessel. So this is, we use an ELMA machine. You can use any machine which is a source for endovascular, and you got various tips which are available there. Now that's a very important tip which is there. Mostly, we use either 2 to 6 millimeter tip. And as I told you, 2 millimeter tip means a small diameter tip, and 6 millimeter tip will go deeper. 2 millimeter tip will be on the superficial. And looking into the pulse width and the energy densities, as I told you, fluency means the power, how much power you want to give. So you want to burn more, you give more fluence. Pulse width is, as I told you, depending upon the size of the vessels. So normally, if you look into the telangiectasias and all, so we use around 15 to 45 milliseconds. Normally we use a 6 millimeter tip. And normally in terms of fluency, we can use 30 to 45 or 50 to 60 fluency, depending upon the skin of the person. So that's why this, which we discussed before, thermal relaxation time is very important. So if you have a smaller diameter vessel, then you keep your pulse width smaller. So you keep the pulse width at 12, lesser than the 20 milliseconds. So that's very important. So if you want to keep pulse width of 15, then you can keep up to the diameter of 200 micrometer vessel. But if the vessel is very small, let's say 100 micrometers, so then you cannot use this pulse width of 12. So you need to use a lower pulse width. So this is a very important last slide. As I told you, the spot size is very important depending on the diameter and the depth. So smaller vessels, smaller spot size. Pulse duration we have already discussed. Fluency we already discussed. Now fluency is very important. Smaller the vessel, higher the fluency, higher the energy we have to use. The reason for that is because if you have a smaller vessel, you have less hemoglobin there. So less hemoglobin means more power is required to burn it. If you have a bigger vessel, you got a lot of hemoglobin where the laser energy will be absorbed, then you can use a lower fluency. So it's opposite. So smaller vessel will require a higher fluency and a larger vessel will require a lower fluency. So this is the sort of a setup what we have. If you look into the left side, it's a pulse width. You need to adjust depending upon the thermal relaxation time, which depends upon the the vessel size. Then you have a fluency, which we have already discussed. And the spot size, you can keep 2 to 6 millimeters. And the cooling, you can keep around 75 to 100%. This is just depending upon the protocol, what we have, depending upon the skin type, because you have to follow, once you do it, keep on doing it, then you remember this, that fairer people have got less melanin. And so you need to be careful about what sort of powers you are using. So in the end, I'll say be a responsible laser clinician, and so you should know your equipment very well before you start using it. Thank you.
Great, very nice presentation. I think we learned a lot about the basics and the amplification of laser. Mm-hmm. And I think it's time to have some comments and questions.
Yes,
questions?
Yes, we are delighted to have Professor with us. He did give a fascinating lecture in China this morning, and he had a question that he wanted to say to Raul. So you can ask your question, Mark, and you can unmute yourself.
Sure, thank you. Welcome, Professor. Sorry I missed your lecture today because I was stuck in some emergency today, whole day.
It's lovely, isn't it? The one thing we've learned about COVID-19 is you can talk in China in the morning, Egypt in the afternoon. It's fantastic. That was a
It's midnight over here.
Oh, midnight. Oh, it's early evening here, just in time for wine later on. That was a masterful talk. I thought that was absolutely fantastic. And I wrote my question halfway through, and I think you might have come across it and answered. I'm very interested in the absorption of the wavelengths for endovenous surgery. We know that with 1470 nanometers, there's quite a lot of transmission before the full absorption. Because if we forget 1940 and we go to the ablative lasers, like the 10600, which is another 10 times further on, you shine that at a surface, and ablated, it doesn't even penetrate at all. So we've done a bit of work, which you probably know, with the 1940. And although we work for very thin layers, if it's very thin, so you get some transmission, it might be absorbed more. When we're talking about veins and we're looking at the heat transference, the amount of energy you put in with 1470 and in 1940 actually is more or less the same. It's just how it's absorbed. I mean, I don't know what your feeling of that is, but I don't think wavelength makes that much difference between the two.
Yeah. You see, Mark, I've been from last 1 year, because we started using 1940 around 6 months back. And then I got really interested into the physics of lasers. I thought, right, let me get into this. Really, is there a difference? Because, all the book chapters, whatever we read, they put in only very superficial. Then from 6 months, I've been just reading and reading about this. And then I came to know, actually talking, if you keep on reading the publication on the laser physics, we keep on knowing more and more that actually talking, we don't know how does they work. And if you look into the concept, because whatever the machines or whatever the literature we hear, that the heat energy from the laser 1470 or whatever, it gets better because it's absorbed more by the water molecule, as I mentioned here. It actually, there is not a single laser physics paper which supports this idea. And actually talking, there has been publications, sorry to say this here, there are a lot of publications which are there, which are actually anti-company. They say they don't want you to learn the laser physics as a phlebologist, because if you learn all about the laser physics, then it will be very difficult to sell you the machines. Because, there are a lot of publications published. And if you look into this, approximately 13 publications I have on this, against that, there is not much difference. Because that's why I went into the basics of laser physics. Really, how does the laser work? And how exactly it works? Where does the laser energy gets absorbed? And if you look into, there is a guy from Italy who is actually the godfather of laser. If you look into the dermatology, plastic books and all, he is the godfather. And he has written a book on laser. I got that book from there. And he has mentioned everywhere that whatever we know, that the heat energy from there gets first absorbed by the blood in the vessel, not by the water in the vein wall. And because with the various theories and principles, that the nearest to the laser fiber, whatever the things are, first they will absorb the energy, then the heat energy will be absorbed by the other molecules. So there will be some molecule water in the vein wall which will be absorbed. And second is, all the other theories which I mentioned, which are being documented. And another very important point which I came, try to understand was, when we use an 810 nanometer, it used to work. And there was by the water molecule. So how will you explain that?
I think one of the interesting things, and I totally agree with you, the thing is we don't really know all the chromophores, because in the cell wall, I mean, if you think about the cell, you've got all the lipids, you've got the RNA, the DNA, you've got so many molecules, there's bound to be more than just the chromophores that we look at. All these different molecules that are going to be sitting there inside the cytoplasm, so there are going to be other chromophores which we don't measure very often. So I think we're talking about predominant chromophores.
Yeah, but Mark, that's why I put in the chromophores. The basic principles of lasers are, they have to be absorbed by the chromophores, otherwise they will not work. So the fat, because it has to be absorbed by if there is a fat globule, there is the water inside it that absorbs the laser, not the fat. So you have to understand, there are only 4 chromophores. It's a hemoglobin, melanin, water, and the tattoo. So
No, those are the 4 we measure, but that's because what we don't do is we don't actually go back and we don't look at, you know, does DNA absorb, is a DNA chromophore for 8 to 10 nanometer? We don't draw the same curves. We only draw the curves on the molecules that we actually are interested in. But the fact that 8-10 nanometers works shows that there are other chromophores in somewhere in the vein wall. We know it's not as strong as hemoglobin, but there are some other chromophores in there. And there's lots of different chromophores. It's just which ones we bother to measure and do the curves.
Great, this is great. I think you both have a point. Mark, you add a lot by discussing the absorption, which is very important. And you are right, Raul, we have only 4 chromophore. And I think Sergio wants to add something.
Sure. Hi. So first of all, I have to say that I have the chance of admiring Raul on the clinical theater. It was amazing. On the stage, he was outstanding. Now he's also a physicist online. So my admiration can't stop, of course. But I just wanted to brainstorm with you on a joke. You know, the joke that are saying, why do you keep on banging your head against the wall? Because I like it so much when I stop doing that. So the thing is, in 2010, I read a very nice paper of Swat Doganji that should be here with us today. And it was 10 years ago, comparing 1980 with 1470, showing that basically there was no significant difference in the occlusion rate. Yeah. Now, 6 years later, they showed us that 46% of the energy is lost in the carbonization of the tip of the laser fiber, as you correctly pointed out before. We had some experiences with Omnium laser showing about the importance of the cooling effect of the blood that is flashing on the laser. And we know how heterogeneous the tumescence can be done by one operator rather than the other. In 2018, they published a nice paper showing that if you do a meta-analysis of all the data we have, it's a perfect storm of unuseful data. So before going to bed tonight, can you tell us how we should really design a study on laser to make it pretty unbiased? For example, we never quote we never mention the fact that the tributaries have been treated or not. And that could be a bias, for example, for the flashing effect they could have. What are the factors we could consider, in your opinion, in an investigation to make it really unbiased? Because if not, 10 years from now, we'll be talking about the same things, smashing our head against the wall.
I agree with you. You see, what I think, one of the most important things is because we are all running after the wavelengths. And that, you know, it's more absorption, more water, bigger wavelength. And in my clinical practice, we've done like 100 cases. I hardly see a slightly more gentle, I will say 1940 as compared to 1470. But if you don't tell me that this has been done, if I'm blinded on an ultrasound and to the patient, I may not be able to tell the difference at all between 1470 and 1940 at all. And so I personally feel one is we should take this factor out of the picture. So one study we should do is comparison of 1470, 1940 in the same group of patients, same level of energy, so that all the factors, all the other factors are taken off. Because if you look into all the comparative studies which has been published, there is a difference in something. In some factor, they have used more long septness, they have used ASSV, they have more diameters, more thicker, you know, all the factors are included. So even if we have a smaller number of patients, but if you have the same factors, including, because occlusion of the vessel will depend upon the diameter of the vessel, the vessel wall thickness. It will also depend upon, you know, the patient ferritin level, because it will depend upon, you know, how good the hemoglobin levels are. It will depend upon the color of the skin if we are doing the transdermal, but we are talking endovenous, so it will depend upon how much wattage we are using, how much energy we are using in the patient, what wavelength we are using. So if we have only the one same factor, so if you just have one wavelength factor difference, and we do one study, and if we can show that there is no difference, at least one thing is out. And then I think we should work on how how we can increase the delivery of energy from the laser fiber to the vein wall. So there should be an experimental studies on the animals or on the veins where we can see how we can increase the delivery of energy from the laser catheter up to the vein wall media. So we want to damage the media of we want to damage the collagen basically. So how we can increase that. So I think all the studies should be pointed out that, because if we can find a way by which we can deliver more energy there into the vein wall, we'll be winning the situation. You know, it doesn't depend upon what wavelength we are using or what we are using. I think.
Sure. If I can just ask a second thing, since we have also Mark Whiteley, that is a huge expert on this, how much does it matter the thickness, of course, of the wall in the different effects, particularly if you are talking about the small saphenous vein? Because if you look at the Cochrane, we have now data showing that we could just say at 1 year follow-up better performance of lasers over surgery. But if we translate this into the small saphenous vein, do you have, you and Raul, some suggestions for us if, for example, lowering the lead with 1940 could be potentially less dangerous because we are delivering less lead in that case, or not for the small saphenous vein?
Do you want to speak, Raul, first?
It's a difficult question. If you look into this, I feel, yes, why we feel, if you look into the histological study published by this gentleman, I feel 1940, we use less energy, and if you look into the laser physics, I still can't understand how lesser energy will cause you better heat delivery to the vein wall. This I still cannot understand. But we think that if we are able to close the vein with a lesser energy, then there is less perivenous damage, and then there is less nerve damage. Then there may be an reason that we may have less nerve damage with 1940 as compared to 1470. This is all theoretical, I'm thinking. But said that, we have been using 1470 from 8-9 years in short saphenous vein also. So I remember only we had one single case of mild paresthesia for 2 weeks. And so, I really don't know. We can speak to the high volume centers, how many cases of short saphenous vein laser ablation paresthesias they had.
Thank you so much.
We've been doing, sorry, if I can answer that as well. We've done a lot of work, as you know, on the ex vivo great vein and heat transference. And one of the interesting things, and I think this goes to a lot of what I was saying earlier on, is a lot of people are just looking at the LED and forgetting that you can get the same LED with 2 different powers just by changing your pullback. And heat distribution, just the same way as we always talk about as cooking a steak, very, very hot, put it on quickly, you inject charcoal and nothing cooked through, put the same amount of energy in but much slower at a lower level, no charcoal, and it cooks the steak through. We've talked about that for 20 years. And I've produced some figures in my book about the different curves we see of that. And I think the answer with this is sometimes counterintuitively, it's better to lower the power, to put it back slower, to avoid charcoal formation by having lower powers, but just do it slower, and you get a better penetration of heat through the wall. Whatever that formation, however you get the heat, you get it through the wall. You don't get heat lost by charcoal. And what the research we've done looking at immunocytochemistry is you get more cell death right to the outside. What you don't want to do, of course, is you don't want to do it so much that you get the heat going out to where the nerves and the skin are. So there's that balance between not doing it too fast and furious and only getting charcoal on the inside and not treating the vein, versus doing it too slow. And so it's all about understanding heat dynamics, which is both power but also time.
Thank you so much, guys.
No, great. Now I think Dr. Kanata wants to have a comment too.
Yeah, my comment is I saw those 2 presentations, one from Rahul and the other from Mark this morning. I was amazing regarding about the new way that we supposed to change it. Long time ago, we just just do the pullback slowly. Now we have to just, as he said before, we have to move just a bit faster, not too slow, not too fast. Try not to burn the skin and get the carbonization that we usually can have if we're in trouble over there. The slide that you saw, Mark, this morning was amazing regarding about how was the histologic changes and what is the difference. And this is the difference that we have to start working on it. The difference on wavelength, the difference on the fibers, and we have to try and show the difference, try to have a better results for our patients. I think this is amazing. And I ask just a question for you guys, for you, Rabul, and for you, Mark. Do you prefer trying to do the fast pullback or the low pullback? And what is your suggestion for us?
It's a very, you see, in my practical purpose, I'm using an ultrasound actually. So, I'm trying to measure the length of the vein and approximately estimate at how much energy I'm going to deliver in this sort of vein. And then I'm seeing the ultrasound, the vein wall, and trying to just burn the thickness of the vein wall, which you can see, and you can see all the time the bubbles traveling into the vein wall. And so I'm just trying to burn the vein. And every 10 centimeter, I see approximately how much energy I have given. I hope I'm not given less energy.
I also think that the most important thing, as Raoul just said in his talk, you must avoid carbon. And I think the most important thing is if the most energy you can, which doesn't cause carbon. I think once you start causing carbonization, you're losing energy, and also you're concentrating it in the wrong area of the vein. Now, unfortunately, having said that, I'm going to be very unscientific now, and because I have nurses working with me, I set all my lasers to 10 watts. I don't think it's the best, but it makes the mathematics easier. I think probably for a 1470, for a good laser, probably 6 watts or 8 watts is better, and to pull it back slower. But the difficulty is as soon as you start changing things, somebody might alter a setting and a patient gets a bad result. So for practical reasons and not science reasons, I always use 10 watts. But I think you're right. I think it would probably be more precise. I think we should worry about. I think we should worry about results, not time. Is basically.
You have a point.